Assalamu alaikum wa rahmatullah. My name is Dr. Amira Al-Kharousi, and I'm one of the organizers of the Oman Obesity Academy. Welcome to the first day of the series of webinar on obesity management. Today we are welcoming also other participants from the general health sector. All health professionals are joining us today for this course of webinars for free. And we'll come back and sort about the confusion that happened last night. The introduction yesterday was meant for the candidates who have been selected to join us for the webinars as well as training in obesity management. So welcome again today. Today our agenda will start with the obesity assessment for patients in general. And then we will, following that, we will have, it will be 30 minutes only for this session, and then 15 minutes for questions. Then we have 15 minutes break. After that, we will start with the updates from the new Canadian guidelines on obesity management by one of the authors of the guideline, Dr. Judy Shao. Following one of the lead dietitians. So following that, we will have dietary intervention and obesity management by one of the dietitians as well. So we will start with the first session. We are already, I think it is 7 minutes past 4. So I will start the first talk. So first, I will talk about evaluation of patients with obesity. I will, this talk basically, first I will have to, my disclosure is basically I have no financial disclosure or conflict of interest with anything presented in this talk. Some of you might have heard this talk before. I modified it a little bit, but it is basically a comprehensive assessment of obesity. We'll start with how to effectively approach the topic of obesity with a patient, because this is very important. And then what are the aspects of taking history in obesity in general, and what are the measures that we use to measure adiposity, and what is basically the best way to assess these patients physically, and then how to perform a comprehensive physical exam and investigations needed for patients with obesity. We will start with the question, why is it difficult to address weight as a clinicians? Some of us see a lot of patients in one day in general practice, and those patients usually have they come with different issues. Some of them are related to weight directly, some of them are not related to weight, but you see the elephant in the room, which is basically not meaning physically elephant in the room, but meaning the obesity itself is an issue for the patients. And you try to approach the patients with this issue to discuss it. Sometimes the time is not the best. Time constraint is in a busy practice is very well understood that it can be one of the barriers to address weight. Second, lack of effective treatment, and this is probably one of the things that you can relate very well. Like there are not so many treatment options you have for these patients. That's why sometimes you avoid discussing weight as clinicians. Lack of confidence in the training and the management of obesity. Also unsure how to raise this sensitive issue. You can see some of the patients are usually very avoidant when you try to discuss weight in general. So you try to avoid talking about weight with them, knowing that it is a sensitive issue. So these are major causes, and the reason why, because patients with obesity have been stigmatized and ashamed, not only by people in society, but also by other healthcare professionals. If they had a bad experience with obesity discussion before, then they will try to avoid going to the clinic and also seeing physicians, specifically knowing that their issue could be related to weight. So they will try to avoid going to the hospital, and they will usually sometimes miss their appointments. So approaching the topic of obesity is very important, And first thing you need to eliminate this stigma and shame for patient is telling the patient that obesity is like any other chronic disease. So this usually eliminates the blame that the patient feels towards themselves and towards obesity in general. And they usually open up more to discuss weight, especially if you, for example, talk to them about like obesity and how chronic disease it is, just similar to, for example, diabetes and hypertension. And this usually help them eliminate this stigma and bias that they feel, and try to basically to address this in a more pathophysiological reasons as well with the patient. So first you ask permission to discuss weight and readiness for change. This is the first step in talking to a patient with when approaching the topic. For example, if this patient is visiting you for other healthcare health conditions that is not related to weight itself, first you ask if they have any concerns about their weight, or could it be related to, for example, to symptom X that they are presented with, or disease X that they are trying to control. For example, knee osteoarthritis, they are complaining of pain, and they are coming to your clinic complaining of a knee pain, and then you start addressing weight as one of the reasons why they feel the pain. So you ask their permission if it is okay, or do you think it is related, and also if it's all right to discuss weight. This usually help the patients to feel like more safe to discuss this insecure and vulnerable cause. And most patients actually would agree to, it's rarely that you find a patient who tells you, no, I'm not discussing weight today, or I don't think it is related. So the second part of the question, are they ready for a change? You ask them the question, instead of like starting giving them some directions or recommendations of what to do in terms of weight management, you ask them if they're ready to contribute to like a structured program in terms of weight management. So you ask them in a scale from 0 to 10, how important is it for you to lose weight at this time? And I will tell you why we assess this, because there is a readiness of change scale that we use. And you ask them from like a scale of 0 to 10, how confident you are to lose weight at this time. Because basically ready to change or ready to make changes and confident are two different things. So this usually assess them from the perspective of like Prochaska's readiness for change model. And this is where you know where your patient is at. So it is a way for you to build like relationship with this patient and know where they're at in terms of the like change. So are they in the pre-contemplation stage, where the patient has no intention of changing the behavior and does not see it coming in the next 6 months? So probably at this time you avoid like giving instruction in the next 6 months, like a structured program intensive in the next 6 months, because they are just not ready. So, and if they are ready, then they are in contemplation stage. So the contemplation, they are aware that the problem exists, and they are seriously thinking about overcoming it within the next 6 months. So this is usually most of our patients, when they come to the clinic, they know this is like obesity clinic. So they are in the contemplation stage. It happens sometimes they are in a pre-contemplation where they are referred and they don't know why they were referred to our clinic. And then preparation stage, is this patient intending to do anything in the next month? So they already have a plan, for example, to do something, but they don't know what to do. So this is a place where they have intention and some small behavioral change. And then in the action, rarely you find patients coming to the clinic with an action, but it happens. Like some patient already started making some changes. I quit, for example, canned drinks. I already switched, I cut down sugar for the last year. So they have some action stage in between. And you know, these patients usually tend to engage more in a structured program when they are in action stage. Sometimes in a maintenance stage, meaning that patients already lost weight, they are worried about relapse, or they want to consolidate their basically results, and they are coming to you for example, symptoms that are related to why is it hard for me to maintain weight? If I just open up a little bit, then I started regain weight. So they might come to you in a maintenance stage, especially I would say post-bariatric patients. They usually come in this stage. So they go back to the clinic for this reason. So this is called Prochaska's readiness of change model. Then after that, one of the things that I want to discuss, and I think it's very important for us to address this issue, is how to use the people first language for patients with obesity. So we try to avoid labeling patients with their disabilities or diseases. So we don't say anymore diabetics or obese. We say, for example, patient with diabetes or patients with obesity. And this is one of the actually one of the action plan that was brought up by the Obesity Association, and it was led by patients with obesity. And this is one of the things that they addressed, that they don't want to be called like by their disease. For example, diabetics or obese, you have schizophrenics, for example, or you have patients like sicklers. We use this a lot. So we try to avoid using these labels, and we try to say, like, instead we use the person first, like patient with obesity or patient with diabetes. Also avoid a description that victimize patients and making some kind of emotional helplessness feeling with the patients, like afflicted with or suffering or struggling or stuff like that, because this is also important if you are actually writing this in your documentation and your health records and giving a patient handouts. I know it's in English and patients are Arabic speaking, but you will face some patients actually who know how to read English, and then they would basically, this would make them feel not comfortable or ashamed. So the goal of the initial conversation would include basically the first thing, that when you try to minimize stigma and bias, you talk about how is it is chronic disease, and then you tell the patient how they would benefit from losing up to 5 to 10% only of their weight, can help manage most of their other chronic diseases. And then you convey the risk associated with excess weight, but without making them feel or provoking fear, because provoking fear sometimes cannot help patients make a movement. They will feel more of helplessness in these terms. So exploring with the patient their motivation and readiness, and why would they want to lose weight? And this means drivers. Why would they want to do a behavioral change? Why is it important for them to actually to lose weight? And then why is it difficult for them to lose weight? Talking about history taking, we will go through their previous, for example, attempts to lose weight and what were the barriers to lose weight. And then the final step in your discussion in your first visit with a patient is giving a practical lifestyle changes and a short-term goals that has been shown actually to be the most effective in patients in a long term. So it's very important when you speak to the patient to be non-judgmental. Do not blame, threaten, or provoke guilt. Like, don't do this, you will die by next month. Or if you don't, for example, exercise now, then you are unlikely to start moving afterward if your weight increase. Something like this, we try to avoid provoking any kind of fear, guilt, or threat in patients. Tell them about their risk, like the risk associated with excess weight, but not specifically in a provoking way. Do not make assumptions about their lifestyle or motivation. Okay, it cannot be, for example, your A1C is 10 and you are cutting down sugar. For example, this is one of the assumptions you can sometimes make about their lifestyle. So try to avoid making these assumptions. Also acknowledge that weight management is difficult and hard to sustain, because it is. And more and more studies on obesity science has shown that is actually it's a relapsing remitting disease, and it's not easy for patients to actually maintain a lower weight when they're born, especially with obesity. So one of the things that I did not mention here, but it's very important, is your facial expression with the patients. Like, if a patient tells you how much he would eat fast food in a day, or how many cans of soft drinks he would drink per day, try not to raise your eyebrows or make a facial expression that actually judgmental in a way. So this is one of the things that will make patients comfortable when speaking to you and also come back to the clinic. Then how do you initiate the assessment? The first part is always history. We all finished medical school. We know how to take a very good history. However, certain aspects in patients with obesity you need to address, other than the demographics that for example, the age, the sex of the patients, and what are the relation between these demographics and ethnicity, for example, and obesity. Personal and family medical history is important. Psychosocial assessment is as important. Nutritional history, physical activity, as well as weight history. So in the medical history, I will not go in details, but you need to go through thoroughly to the all medical conditions that are linked to obesity, whether it is diabetes, dyslipidemia, hypertension, OSA, osteoarthritis. I would have a slide showing all these medical conditions, and I'm sure you guys are aware of the medical conditions associated with obesity or malignancy, for example. Are these conditions being treated at target? Because this is also important part of the medical history. For example, is their A1C at target? Is their dyslipidemia control? The blood pressure is okay, and so on. And whether these conditions can influence your obesity management strategy as well. Mostly, like we're talking here about like diabetes, but some other conditions that you can actually treat both the chronic disease, for example, diabetes, and also obesity at the same time, using GLP-1, for example. And then the level of functional and cognitive impairment, if exists, if any of these exist, of course, that would affect your management because you will give instructions to patients based on that. And are there any medication that can cause weight gain? And I will stress on the part of medication because many patients who are referred to the center are on multiple medication that can cause weight gain that we try to also adjust. So I will tell you more about, I will skip the slide about the chronic conditions that are associated with obesity and how to screen them by symptoms, but you can have these slides and then go back to them. So because I want to go to this slide, there are many drugs that can cause actually obesity. Try to avoid them or use alternative if you can. If you can't, then that's okay. We will talk about using other like ways to address the obesity associated with medication. But in general, neuroleptics medication, for example, if patients on antipsychotic therapy, they most of them cause weight gain, but there are some alternative that can be sometimes weight neutral or the less weight gain associated with them. So when you have these patients, for example, try to liaise with the consultant physician who did prescribe the medication, whether they will be kind of willing to switch patients to less like weight gain medication. And I will alarm you now saying that most of these medications we don't have them available everywhere, but it's worth discussing with the consultant because we don't know, things are changing eventually. So tricyclic antidepressants, many patients that come to the clinic on amitriptyline, some of them, they don't know why they are on amitriptyline, sometimes because of the aches and pains. I know it's used for fibromyalgia, but assess your patients. If you start them on amitriptyline, for example, assess them if they are actually helping the patients or not. If it's not helping, then stop it because it can cause weight gain. And then also these are one of the things that like I see the most. And then we have like SSRI. Most of them cause weight gain. Even fluoxetine here in this graph, it shows like it is in a possible alternative, but also it is associated with weight gain. We don't have escitalopram, but we have citalopram, and citalopram is actually causing weight gain. But propropion and Wellbutrin, sometimes trazodone can be used, and they are causing less weight gain for these patients. Anticonvulsant therapy. If your patient's on anticonvulsant therapy and they're seeing neurologists, maybe refer back for a possible use of topiramate as an alternative, because we know topiramate is also used as one of the anti-obesity drugs in a combination with phentermine, and it's called Kysima. So it is one of the drugs that can be used also for weight loss. And especially if you have a patient on migraine. So instead of starting beta blockers like propranolol, because propranolol associated with weight gain, then you can switch to topiramate as a maintenance therapy. Antihistamine, there is an overuse of antihistamine. I've noticed this in the last year. We are overusing antihistamines as well, and it can be associated with weight gain, especially the first generation antihistamines. Steroids if we can, for example, beta blockers. Beta blockers, I mentioned propranolol, but also atenolol. Atenolol is also causing weight gain. So if you have a means for using selective beta blocker, like carvedilol would be better, but it is not available everywhere, and I know this. And then basically we have other alternatives that can be used as well, other than beta blockers, if it is for only blood pressure management. Of course, like each indication, it depends. Like if you must use it, you should. But if you can avoid it, then that's the best alternative. Use of contraceptives. Of most of contraceptives can cause weight gain, especially the estrogen-based contraceptive. This is controversial whether it is water retention or weight gain, but most studies show that estrogen-based can be causing weight gain, but progesterone alone contraception can be actually weight neutral. When it comes to weight history, very important questions that you need to take in details that would basically help you with management as well as finding the etiology of obesity itself. So the pattern of weight gain and weight loss over lifetime is important. For example, did it start in childhood or puberty or after menopause? This is kind of more physiological, except for childhood, which can give you like an idea about genetic or environmental causes, but physiological gain is present after puberty, after menopause usually. So weight gain with pregnancy and not losing weight after each pregnancy, which is the most common I think I see here, is like consecutive pregnancies without weight loss in between, usually gradual weight gain over the years for most women. What is the duration of weight gain and the age of onset? The duration is important sometimes if it is very sudden weight increase in weight gain, like in less than 6 months, then you would suspect other conditions, like for example endocrinological conditions like hypothyroidism and so on. Age of onset, if it occurred in other than the other physiological condition that we've mentioned, and certain age and why it was at that age. Sometimes it helps you navigate where patient's social life can also contribute to weight gain. What is the highest weight and what is the lowest weight? So for the patient, why? Because this is a way to help you manage their expectations in terms of weight. So highest weight patient, for example, at where the patient was, and what is the lowest weight. So if the patient, for example, lowest weight ever was 100 kg, and their expectation to be 70 kg, but they have never been 70 in their whole adult life, then that's like, for example, is unrealistic expectations for patient. So we try to navigate those, especially in patients who are like older and they are trying to achieve the weight that they have been with like in their teen years. So set point weight, there is no specific definition of set point weight, but when we ask a patient what is the weight that you have been most at, like in your life, in your adult life, they would have always like fluctuate between 75 and, for example, and 95, or sometimes it's shorter than this, like 75 and 80, for example, and then you will know that this is the set point where patients weight mostly at. And this helps you like know why patients will, after every attempt to lose weight, they will stop at this set point weight. Weight trajectory, whether this is a gradual increase, sudden onset, which is, as I mentioned, diseases, usually cycling of weight. So cycling of weight, it's indicate two things: either frequent dieting, and these patients like have multiple attempts to lose weight, and maybe we need to do something different, or cycling can be because of a binge eating disorder, which I will talk about in the next slide. Was it associated with major event? Like sometimes it can be associated with, for example, a trauma in the past, death, car accident, which tells you that there is also psychological components to the weight gain. What are their previous weight loss, or what are their previous weight reduction attempts, and whether it was like nutritional or with the physical activity or with medication. And when you discuss those, you discuss also what are the successes, how much they lose with each, and what are the challenges and the barriers. And this help you basically formulate a plan in terms of what to do next. This is an example for one patient, for example. It will tell you how after college they start to gain weight, their first job, first children, and then basically they do commercial weight loss program, they lose weight, they quit smoking, they gain, and then basically like longer working hours. This is just an example of how trajectory of weight can show. Social history is very important, and it starts with where does this patient work? For example, are they night shifts? What is their working hours? Working long hours basically does not help them. For example, like following a dietary plan that's very strict. You need to find an alternative that are easier. easier for them. So that would help them basically stick to the plan. What is their financial status, what they can afford, what they cannot afford. Educational level is very important, especially when basically what terminologies we use and how to describe what dietary knowledge they need to basically we go through in details or not. Stressors in their life, whether it is financial, health, or family related, marital status, living situation, presence of family support. Very important, the sleep quality and quantity. How long, how many hours do they sleep? Is it enough? Is it a good sleep? Do they feel rested? Is it interrupted? Do they wake up at night? How many times? And so on. The screen time, we know we use this also for adult. Screen time is basically like watching TV after working hours for 3-6 hours without moving. For example, this is one of the reasons as well. Active substance use, alcohol, smoking as well. Quality of life. Quality of life is important because how is basically obesity is affecting their quality of life. I can tell you, for example, some patients we have, they're not leaving their houses because of obesity, and they are unable to do basic, for example, like self-hygiene and stuff like that. These patients with impaired quality of life may need a drastic measures as well. So in psychological assessment, we usually prefer an anxiety and depression to be screened for all patients using PHQ-9 and as well GAD score, and you will find these actually in Arabic version in the internet that you can use it. In the hospital we are using has a score. You screen for eating disorder, whether like all eating disorders that are not associated with obesity. The 3 that are mainly associated with obesity are binge eating disorder, bulimia nervosa, and as well as night eating syndrome. And I've seen actually a lot of binge eating disorders in Oman. Today I've seen bulimia, nighttime eating syndrome as well. We have very common. So screening these patients for those and find like resources that can help for them, whether it's psychotherapy or refer them to psychiatry and stuff like that, is very important because it's part of the management plan. Food addiction scales, if you find a patients have kind of addictive behavior towards certain type of food. For example, they cannot sleep unless they have it. They will have to drive like long hours to get it if it's not nearby. So these kind of an addictive behavior is sometimes associated with patients' previous use of substance, and they quit and they start developing a food addiction. And sometimes it can be like a food addiction from the beginning without like a previous history of substance use. But it's one of the actually controversial topics in obesity management. Personal history of abuse, which is very important, like whether it is mental, physical, or sexual, because basically eating disorder, when it shows, or depression or anxiety, is only the tip of the iceberg. Down there, it's usually a previous history of trauma. So screening those patients, if they denied any history of anxiety, depression, or any eating disorder, then previous history of trauma can actually help you predict what the presence of these conditions. As well, if you have patients are going for bariatric surgery, then you need to basically to know if these patients are more prone to develop any of these disorders post-bariatric. And we'll talk about this in another session. So very important to remember, untreated mental health actually can slow down your weight management. So first, if you screen a patient and he's positive of any of these conditions, then you have to refer them to a psychiatrist to treat mental health. And then we can think about treating obesity as a secondary causes. Sometimes like obesity and mental disorders are combined together. Patient would have like mental disorder related to obesity because of their obesity, and treating obesity can be also a primary, but always these patients need to be seen by psychiatrists. Then I will talk about binge eating disorder because it's common. Again, it's basically uncontrolled episodes of eating, usually in the evening time. If you suspect binge eating, if a patient have weight cycling and they have a rapid weight change as well. So the criteria we're using is DSM-5 criteria. There is also a binge eating disorder scale, 7, I think it's called. It's very quick and easy. You can have it in your office and then basically ask the questions on the go. But mostly it is 3 of the following at least once a week for 3 months. If it is consistent for 3 months and at least once a week, then you can classify it as a binge eating. So what happens is, the patient is usually eating more rapidly than normal, very quickly. They have loss of control. They would tell you like, I am losing control, I am disconnected. And eating until I'm feeling uncomfortably unwell, like the patients will feel that they will basically vomit after that, or they eat large amount of food when they are not physically hungry. Sometimes I use the term saying that, do you usually eat more than of what one person can eat? And they would tell you yes, like the proportion will be way too big. And then eating alone, fearing to be judged, or feeling guilty or depressed after eating, and then basically distressed about the behavior they did. And they do not, very important, is that they do not have a compensatory mechanism. I didn't mention this here, but usually they don't have like they do not induce vomiting, or they do not go and do excessive exercise afterward, because these will tend to be like more of a bulimia nervosa, like when they start to have a compensatory, unhealthy compensatory mechanism. So nutritional assessment is one part of the assessment. Now, there are 2 ways of doing nutritional assessment, whether you will do a quick 24-hour recall and then you have a dietitian who will do like a further detailed assessment for the patient. But what I usually do in the clinic 24-hour recall, you can use the 7 days food records. If your patients come into your clinic, you can give them like a food log, or they can come back to you with the like written diary of what they had in a whole week. And then food frequency questionnaires, you can find them online. Tracking apps like FitnessPal is used mostly by most patients. Like food plate pictures, especially in those who are like elderly, who cannot like, log write or do any of this, they can take pictures of the food and they show you next visit. There are 2 aspects of nutritional assessment. There is the food intake and there is the food behavior. You can go through this, but the food intake basically discusses the amount, the frequency, the source of food, from where, how many times outside, what is their hunger level, what is their eating, if they are eating when they are full or not, the macronutrient breakdown as well of food, whether it is more carb, protein, and so on. And then food behavior will include cravings, emotional eatings, triggers of intake, eating alone or with family, on their own plate or shared plate. Do they pre-proportion their meal? Do they eat before bedtime or evening snack at night? Are they slow eating or fast? So this tells you about some of the behaviors that you can modify as well. When it comes to physical activity assessment, you have to go through like are the limitations for patients to exercise. Like, is it like a trauma or pain, endurance, like getting breathless and short of breath, they cannot like continue walking, whether it is like time. I did not mention time, but time was one of the most common actually reason why patients don't exercise. What is their current activity, if they do any, like with the duration, the type, and the intensity of the exercise they do, whether they have any previous likes and successes and failure. It's very important to encourage patients to do something they like, so it can be persistent and they maintain it for a longer period of time. And then basically environment and access to if they have any access to equipment or a place where they can walk around their block or nearby their house, or accessories at home, whether it is equipment or otherwise. Now we'll come to the assessment of adiposity. So after you finish your history, now how do you assess patients' adiposity? Meaning, how do we assess obesity in general? There are different tools. The most common is the body mass index, as we all know how to calculate body mass index. So there are usually, in the past, there were 4 classes. The new Canadian guidelines actually added class 4 and 5 until BMI above 60. But these classes, basically, I use them personally only for using like a clinical indication to something, whether it's starting pharmacotherapy, referring to bariatric surgery, because most of the BMI classes are used for this reason. I do not discuss normal BMI with patients at all, like a healthy BMI, because sometimes it's not attainable and it is not a good actually indicator of adiposity. We don't no longer use terms for extreme super morbid obesity as well for patients with these conditions, like depend on their classes. So in terms of the ethnicity in Oman, we are using actually European, which is these classes. However, recently most guidelines separated actually South and Southeast and East Asian ethnicity into different classes where they have actually more comorbidities associated with a lower BMI. And I suspect actually we are falling in this range, but we don't have any literature to support that yet. Why BMI is not such a good indicator of of patients' health or adiposity, because it's not directly measuring the body fat or cardiovascular risk or health, unlike like waist circumference, for example, that we will talk about after. And it does not indicate the body fat distribution. For example, in this picture, a muscular guy who is very fit, who is very lean, maybe their fat mass or is less than 12%, compared to someone with the central adiposity can still have the same BMI. So that's why it's not such a good indicator. So does not account for the muscle mass again, and it can underestimate the body fat in those who have lost muscle mass. So your patients might actually lose weight, but it's mostly muscle and they have sarcopenic obesity, but it's still getting like a smaller or same BMI. It is not accurate to use in elderly or those who are younger than 18 years of age in pregnancy, or anybody who has like any sort of a fluid retention, ascites, or severe edema. The second assessment is a waist circumference. However, waist circumference, we cannot use it. It's in a BMI above 35 because it did not show actually a good correlation with cardiometabolic risk in ages above in BMI above 35. So for women, we are using again the European guidelines or cutoff, which is in women less than 80 and men less than 94. Again, I'm suspecting that we are actually lower than this because we see patients with, for example, diabetes, and their waist circumference is much less than this. Limitations is usually if there is any abdominal distension due to food or fluid intake or bloating or ascites or pregnancy, you cannot use these cutoffs. So hopefully in the future also we have our own data, and we can extract our own cutoff for the waist circumference. Now, other like physical assessments that you might want to use is measurement of basal metabolic rate. If you are using this in your own clinic, calculating for each patient, Mifflin equation is preferred for obesity. And if you are using calorie restricted diet, for example, with your patient, then you can use the basal metabolic rate. Bioimpedance analysis, it's not a must for all patients, and it is basically, it is practical to use for body composition. Patients sometimes they like to see how much the fat mass, for example, drop, and it has some kind of a motivational factor there. But generally, it is not like a must assessment for all patients. So in terms of your physical exam, a comprehensive physical exam, very important to use appropriate size cuff for patients with obesity because that can make a big difference in terms of like the blood pressure. Screen them for secondary causes, whether it is like Cushing or hypothyroidism, whether it is by history and also by physical exam. Look for the complications of obesity, the OSA, PCOS, and diabetes as well. So I will leave this slide. I will not go through all the physical exams that you do for patients, like for every patient in terms of like assessment, but in general, it is from head to toe exam for these patients. Especially if you're suspecting like certain condition, then you go ahead and look for this condition in your first assessment. But usually it's striking, and you can see it right away when there are secondary causes. So what are biochemical investigations you need to do for patients? It's not generally recommended to do now cortisol and sometimes TSH for all patients, although this is from the guidelines, but I do TSH for all patients if I see them for the first time. But generally you do the A1C, the lipid profile, their kidney function, ALT looking for fatty liver, age-appropriate cancer screening for all patients, because we know the association between obesity and cancer is recommended. If clinically indicated, for example, patient going for bariatric surgery, he's diabetic, he has diabetes, and you want to do urine analysis and microproteinuria, then it's recommended. Only screen for other causes if you suspect it, like Cushing, hypothyroidism. I didn't mention here PCOS, but is one of the things that you can look for if you suspect it clinically. You can stage your patients based on the Edmonton obesity staging system. And like, you know, where the patient stage is, where it will help you basically to see what kind of intervention you need. If it's patients stage 3 and 4, what do I need to like refer to surgery right on, or do I need to address this with the patients to take like more drastic measure at this time from the beginning? Like stage 0, there is no apparent risk factor. Stage 1, for example, diabetes, pre-diabetes. Stage 2, usually they have established comorbidity like diabetes or hypertension or OSA. So it's just only for you to like to classify patients and you know what kind of a management plan you want to go through with the patient. So we have, this is like my last slide. Hi, Dr. Shao. So 5 minutes and I'll be with you. So in summary, never delay asking patients about obesity, like treatment and options if they want to cover obesity, like if you want to cover obesity assessment in your clinic. It's a chronic disease. There is a need for long and close follow-up, just like diabetes and hypertension. Always screen patients for mood and eating disorder is very important. It's common in Oman, like anywhere else. It's not about the BMI. This is one of the things that I want to always everybody to take from this presentation. Secondary causes of obesity, less common. Test them if you suspect secondary causes. So this is the end of my presentation. So so Dr. Shao. Hi, 1 second. I will just turn on the
Please, Dr. Shao, unmute your mic.
Dr. Shao, just yes.
Oh, yes. Hi.
Hi, Dr. Shao. So I was talking about evaluation of obesity as part of today's workshop is actually me, evaluation of obesity, and then you talking about the guidelines. And then we have Daniel Aldos, who will talk about dietary intervention in obesity. So before we start, I will introduce Dr. Shao. Just give me 1 second. So Dr. Judy Shao is Associate Professor and General Internist, and also the Bariatric Medicine Fellowship Program Director at the University of Ottawa. She's also the Medical Director of Leaf Weight Management Clinic and one of the lead author in Canadian Obesity Guidelines, and congratulations about the guidelines. And she's also one of the executive directors of the Canadian Association of Bariatric Physicians and Surgeons in Canada. So Dr. Shao, thank you very much for accepting this invitation.
Well, thank you very much. Let me see if I can share my slides. Where are we at here? So I know we're a bit early too.
Yes, actually 10 minutes.
Yeah. And I apologize, I didn't realize you were doing a talk. I thought I was the first one for this evening.
Okay, it's okay.
Swap shared screen with video. Oh.
Dr. Amira, please stop sharing.
Okay, it's me, so I should stop sharing.
Yes.
Okay.
Now you can share.
Okay, there we go. All right, so hang on.
Sorry, Dr. Shao, I stopped my like video sharing because of the internet connection. my voice.
Okay, yeah. And then I think participants can see my slide now.
Yes, we can.
All right, and I'm just putting up my laser, and you see my laser pointer. And you can hear me, hopefully.
Yes, we
Thank
can.
you so
And
much.
if you want to start in 10 minutes, that's okay. But if you want to start now, that's okay either.
Yeah, I'm not sure if the participants want to have a mini break or want to continue on, keep up the momentum. I'm fine with either. You can decide.
Yeah, we can. I think we can continue. Like you
Okay,
can
perfect.
start the show. Thank you.
Yeah, no, thank you. Thank you so much for inviting me, and thank you for the lovely introduction. And I'm sorry to have popped in with that surprise hi to everybody. But here we are talking about the latest Canadian guidelines that came out in 2020. And I was actually 2 years in the making to get this project going. And, you know, I'm hoping today to give you essentially the essence of those guidelines. These are my disclosures, and I will mitigate any potential bias by really trying to stick again to the concept of the Canadian guidelines. So these guidelines came out in August 2020 in the Canadian Medical Association Journal, and in fact have been the #1 read articles of all of 2020, which is terrific because it really shows the momentum and the curiosity and the passion that people have for the treatment of this disease. In fact, the prior guidelines had been in 2006, so it was a long time coming for us to come out with these guidelines. And for any of you who are curious about it, here is the website for it. I will say it's a bit of a read. You can imagine there was a large team of doctors and clinicians and dietitians serving, trying to do the best research possible for these guidelines. It is focused on adults. And the good news is that the pediatric Canadian version hopefully will be out in the next year and a half or so. Now, the beauty of the current guidelines is that there is actually a section there for patients. So every chapter actually has a section, which are key messages for people living with obesity. And so if you have patients who are looking for resources, these guidelines are also meant for them. The total number of chapters for the guidelines is 19. And I highlighted here in this slide some of the guidelines chapters that I thought were pretty unique and that might be worth your time if you haven't had a chance to look at it, including the medical nutrition therapy, which Danielle Albus will be talking about in a couple of hours. And also a very great chapter, which is unique to any guidelines, which is the weight bias one. So if you have a chance to look at that, that would be great. There's one about emerging technologies, commercial programs, at least those that are available in North America, and then weight management over reproductive years. And then finally, there's 3 chapters on bariatric surgery, of which I'm the one who did the post-op one. And you might find in the post-op one some helpful tables. I really like tables. It simplifies things sometimes when you're trying to look up. That will help guide you in your management in your post-op patients. Now, rather than going through this didactically, every key recommendation, every chapter, which I think most people are able to read quite clearly when they take a look at the chapters, I really wanted to bring out with you the philosophy and the actual concepts that tie in all the chapters and put you through a journey of how we manage obesity and how we view obesity now in our current environment. And essentially the objectives would be to highlight the complexities of obesity, the role of the brain, which, you know, some people are like, what? The brain's involved in obesity? And then really bring out that 3 pillars and post now approach that we have towards treatment of obesity. And then finally, develop an approach of how you would talk to a patient, and also what the role of weight bias is as we approach our discussions with our patients. So as we know, obesity levels have been increasing in prevalence, almost doubled since the 1980s. In Canada, we actually actually, quote, 1 in 4 adults are living with obesity and 1 in 10 children have obesity. So what is key in the guidelines now is our definition of obesity. So rather than using the BMI, which is classically greater than 30, to diagnose obesity, we now view obesity as that complex, progressive, and relapsing chronic condition, but it's characterized by hyperadiposity that causes pathology. Okay? It's excess body fat that actually impairs health. So what does that mean when we see a patient? It may mean that we actually do see a person with a BMI greater than 30, and they actually have no comorbidities. They're actually pretty healthy. And you know what? They don't have the diagnosis of obesity then. The opposite occurs too, in that we might have a person traditionally characterized in an overweight category, but because that excess adipose tissue is now causing harm, such as prediabetes, insulin resistance, and so on, they would be characterized as having obesity. So this is a concept that we've brought out in our Canadian guidelines, but it comes with a bit of controversy and a bit of difficulty too, in that as we were looking over the 2 years of research, pulling all the best studies and putting it together for the guidelines, pretty much every study is based on weight as an outcome. The other aspect with respect to trying to get away from the number, but it being difficult to do that, is that a lot of the criteria for treatment are still based on BMI. So a bit winds up having to go towards the clinician to make the best judgment possible. But what we're hoping for is, as we progress with research in the future, that we do step away a bit from that number on the scale and start looking at non-scale wins for a person who is trying to manage their weight. So here's another concept about obesity that I think many of you are familiar with, is that it is super complex. And essentially, it is not only the individual who is responsible for weight, there is a complex interplay between environment, genetics, society, etc. And truthfully, a person who is living with excess weight actually has very little within their control other than their behaviors. And that would be what you kind of see here in red. Okay? Everything else, you can't control the family you were born in. You can't necessarily control your environment, your social circumstances. You certainly didn't control the pandemic. And we definitely know that people gain weight during the pandemic years. And so what is it that an individual can control? And it can be limited. And knowing that as the clinician trying to help someone living with excess weight is important, because that helps mitigate some of that bias and shame that an individual that's trying to manage their weight undergoes. The other aspect with respect to weight management is the following. Losing weight is one part of weight management, but keeping it off is the other. And we already know that our body is naturally there to defend the higher weight that a person has been at. It's the process of genetic survival. So two big things occur when a person tries to lose weight. We know that there are a series of hormones that act on the brain that signal hunger and desire to eat. And in fact, there are actually more hormones out there that are supposed to make us feel more full. And really one hormone called ghrelin that is there to make us feel more hungry. And you think, oh, that's wonderful. We have more hormones out there trying to make us feel more full, and one only that's trying to make us feel more hungry. But when somebody loses weight, what happens is those hormones that are there to make us feel more full actually decrease, and the hormone that makes us more hungry increases. So it's not surprising that when you're trying to help a person manage their weight and they start losing weight, they start saying, you know what, I'm hungry, or I'm starting to think about these foods. And you know what, that is normal. Okay? And unfortunately, these changes in hormones don't last temporarily, they last for quite a long time. Another factor that can be impactful that deters our ability to manage weight long-term is the process of adaptive thermogenesis, where our metabolic rate actually decreases more than what you would expect for the amount of muscle mass and so on, fat-free mass that might be lost with weight management. So a person who used to run a certain amount of time on the treadmill now doesn't burn as much calories at a lower weight. So these biological factors are outside of a patient's control. And again, very helpful for a person to know that, because it generally just states it's not their fault. Now, here's another concept I want to bring out from the guideline, which is, what is success in weight management? So let's talk first about that number on the scale. And let's remember one important factor. It is very normal, if you're at a certain weight, and you can see my pointer here, that there's a natural course of weight gain over time. So you can see I, as an individual, over the years can gain anywhere between a pound, half a kilo to a kilo per year over time of life. That is normal. So what if I'm an individual at a certain weight and I go through an intervention and I lose weight? I lose weight and I reach this nadir several months later. Now, ideally, in the ideal world, my weight stays stable for a number of years. And so this line here remains flat. But we know from every study that exists, essentially, that the curve will typically go down with an intervention and at some point starts to creep up again. And so you always see this kind of curve goes down and curve starts going up. Ideally, the slope between where this line starts going up is as small as possible. But you can imagine, as an individual, as they're going day to day, months to months, through their lives, and they start seeing the scale start to increase, what do they say? They say that they're failing. They start doing, or the system is failing them. They start to get upset. And then they start doing the health behaviors that was actually being successful for them. So it's important to share with patients that they're actually still doing well and that there's a natural kind of curve that occurs. Now, here's another aspect. Even if the curve is going up, notice they're still below their baseline weight that they started at, which is still a win. But what if they do go back up to their baseline? Well, here's another win. They are actually still theoretically doing better had they not done an intervention, because they're below where their natural course of weight would have gone had they not tried that intervention. So you're painting the landscape of the journey for a patient. Now, this is, of course, talking about success with a scale. Our guidelines are really trying to also push talking about the non-scale successes. And the non-scale successes that you can draw out from a patient's journey is that, wow, my energy levels are better. Wow, I was actually able to come off some of those diabetes medications. So those are the types of wins that we need to make sure that we bring out for our patients as they're trying to manage their weight. Now, this is a shift of how we start to view our treatment options for weight. Traditionally, many of you have seen this type of pyramid, where it's really layering intensivity of different treatment options, from lifestyle to medications to bariatric surgery. And that's the typical type of pyramid that you see. But with these guidelines, what we try to do is now shift from that pyramid to the pillar and post model. Or another way of viewing it is pillars that are supporting a roof. And that roof or post is actually diet and exercise, or the chapter is called medical nutrition therapy and physical activity. The posts that are holding up the house roof are psychological interventions, pharmacotherapy, and also bariatric surgery. And so now let's deconstruct this, and you'll see this will match also each individual chapter of the guidelines. Let's talk about that roof, the medical nutrition therapy and physical activity, or diet and exercise. So diet and exercise are words that have come to have some kind of negative connotations in society. Diet being viewed often as very fleeting, that people are just go on a diet and it doesn't work for them. Exercise, similarly, some people might not like the word exercise. They actually prefer the word, activity, a little bit less, daunting to think about. Just let's increase activity versus let's do an exercise program. So the language used in our guidelines have become a bit more medicalized for diet in that we call it medical nutrition therapy. I do think that's a little bit too bad, because I do think this was a chance to take back the word diet, because truthfully diet is just, what you eat. But in the case of the guidelines, we call it medical nutrition therapy, and the chapter is physical activity, not necessarily focusing on the word exercise. Now, why is it that society and maybe even the medical community views diet and exercise as not really that much helpful for a person in terms of long-term weight management? And here's a systematic review that actually kind of fed into that concept. It looked at a number of diet and exercise programs and viewed the results of these different programs over a year. And as you can see, the weight loss that occurred ranged from 5 kilograms to up to 30 kilograms in some of these interventions. So it worked, didn't it? But the question is, what happened 4 to 7 years later? So looking at this, the systematic review noted that, weight went up. And in here you see the gray of where weight on average wound up being for these folks. And so the end result of this study was diet and exercise doesn't work, why bother? I would say now we go back to that principle of what is success in weight management. And I would argue, hey, you know what? These patients actually did pretty well. They weren't on any other additional pharmacotherapy or anything like that. They stayed below their baseline weight. And if you think again about that slide that I showed you, they're below their baseline, and they're actually below what they theoretically could have been had they not done the intervention. So I would actually call this a win. Now, their chapter of exercise or activity in the guidelines, just to summarize it, essentially, activity as we know it doesn't necessarily help with weight loss, but it certainly can make an impact with weight maintenance. But also there is a huge amount of health benefits with activity by itself, including improved cardiorespiratory fitness, improved insulin resistance or sensitivity rather, decrease in adiposity, decrease in waist circumference. And so these are the wins beyond the scale. With respect to medical nutrition therapy, Danielle Aldous will be talking and deep diving into this chapter a lot more. I did want to share with you this lovely table because I am kind of a table person, as I said before, where it's great. It actually went through all of these different types of dietary patterns and looked at the evidence of the impact on not only just weight, but on, say, waist circumference, body compositions, metabolic factors, and just displays it all. It doesn't say that one pattern is better than the other. It's just showing you the different patterns and evidence behind it. What's the good news? The good news is diets work, okay? But the question is, find that medical nutrition pattern that an individual can continue. Or let's say there is a pattern that's working for an individual, then how do you move forward in keeping that pattern going? Or if it's not working anymore, what's the change that we should do? I am going to bring up the Look Ahead study. The Look Ahead study, I think many of you are familiar with. Essentially, it was a study on people living with diabetes and moving forward in time, randomizing groups into an intensive lifestyle intervention versus a standard diabetes education program. The idea looking at trying to see reduction in cardiovascular morbidity. The study ran for several years and had to be stopped because that primary endpoint just wasn't showing up. But a whole bunch of other data came out, including that those who went to the intensive lifestyle intervention were more likely to keep off weight as compared to the standard group. And so when we looked at those patients with diabetes and the factors that actually helped them manage their weight years later, the factors that came to play were, one, they actually had those in the quartile with higher physical activity, those who actually attended those intensive lifestyle behavior sessions, and they were weekly, those who actually used a partial meal replacement strategy. And for those of you who are not familiar with the concept of meal replacements, this could be a strategy where you replace one or possibly two meals in a day with a meal replacement to help manage the quality of nutrition. And those who lost weight more in the beginning, in the first month or 2 months, actually kept better their weight off. This study actually had pretty much no anti-obesity medications. There may have been a handful of people with orlistat. So I'd like you to keep that in mind because I'll bring this up again in another few slides. All right, so I've given you a sense of that roof, that house, that medical nutrition, therapy, and physical activity, which ultimately is what a person has to continue to do to sustain managing their weight. Okay. So now let's focus a bit more on the pillars. The first pillar let's discuss is pharmacological therapy. Now, when I talk about pharmacological therapy, this is actually spread out over several chapters. But the first step really would be is to look at the patient and see what their medications are. And are they actually on medications that could be potentially weight gaining? And so if you look at anti-hyperglycemic agents, certain antidepressants, antipsychotics, etc., is there in this column an alternate therapy? So this table is actually direct from the guidelines, and I find it very helpful because it could be one of the first steps in helping your patient. Another aspect is, well, is there anything that we can do to counter a potential weight gaining medication? And metformin is actually recommended as a potential agent for either treating or preventing antipsychotic-induced weight gain, as you can see from this meta-analysis. Binge eating disorder, quite prevalent. One of the most prevalent eating disorders in adults with obesity. And number one for binge eating disorder is actually treatment with psychotherapy. That is for sure. Number two would be to make sure that a person has good structure in their day. But definitely the role of a medication such as lisdexamfetamine, or known as Vyvanse in Canada, has its role for moderate to severe binge eating disorder. And that would be a minimum of 4 binges per week. And then here is the list of medications currently available in Canada. We have orlistat, as I know you do in Oman. There is also liraglutide, and we also have the combination of naltrexone bupropion. And we know that these medications in general might have an average of a 5% weight loss. We know that they all have GI side effects. We know that they also have certain contraindications. But the point being is that these might be the agents that can really help complement the hard work that our patients are trying to do to manage their weight. And so in the obesity, anti-obesity medication chapter, there is an actual algorithm that we have designed. Now, as you can see, in terms of criteria of who can obtain medications, it is based on BMI, because again, a lot of the publications uses BMI. So here we have a BMI greater than 30 or 27 plus comorbidities. And notice one of the first steps is consider the list of medications this patient is on. I'm not sure if you can see that because there's something here. Move that over. Consider stopping or changing medications associated with weight gain if possible. And then we need to look at the comorbidities or perhaps specific features of a patient. Do they have a insulin resistant profile, diabetes? Do they have hypertension, sleep apnea, or PCOS? If so, then consider liraglutide as the first choice. The combination naltrexone bupropion as a second choice, and orlistat as a third choice. But what if they have a history more leaning towards craving, depression, or they are a smoker? Well, then in the guidelines, we suggest a combination of naltrexone bupropion as a first choice, then liraglutide and orlistat. So remember, those are the 3 anti-obesity medications that are currently approved in Canada. I do believe that in Oman, you do not have that combination of naltrexone bupropion available. I may be wrong, but that's my understanding. And certainly there is that question that comes up of, well, what if I just prescribe them separately and not as the true name of what that medication is? And to tell you the truth, that's doable. You absolutely can. I don't know clinically if I've seen as good a result if as compared to somebody who is on the true medication. But as I've learned also in the world of weight management in our field, you just never know until you try. The question is, will the patient be wanting to or be able to, for instance, even afford a medication? Now, after 3 months of the maximum therapeutic dose, so in this case, it could be, as per the study, for instance, liraglutide would be the 3 milligram dosage. But in the end, some people just can't tolerate it, any maximum dosage. So it would be to the point where they can tolerate the most. And we give it a good 3 months. If nothing has not, well, certainly if it has been successful, we continue the medication. And this is important because viewing obesity as a disease is just like viewing someone with hypertension. If someone has has a history of hypertension, done many changes like lower salt diet, et cetera, but their blood pressure is high, what do? We prescribe pharmacotherapy and they stay on it. Similarly with obesity management, if somebody has tried their best with lifestyle, weight loss perhaps has not been as much as they were hoping for, we add on pharmacotherapy and it works for them, then they have to stay on it. And that is very important for patients to understand because many view pharmacotherapy as just a short-term thing. I'm just going to be on it for a little while, and then once I reach my goal, then I'm going to stop it. And we know time and time again, people start to weight regain after they stop that treatment that has actually been helpful for them. So what if they're not successful with weight management? We can certainly discontinue the medication and try a second line agent. Or here's the following situation. Perhaps the term not successful in weight management, again, maybe on the scale, the number hasn't shifted that much. Yet they've been prescribed an anti-obesity medication and they actually feel a difference. You know what? For the first time in my life, Dr. Xiao, I actually know when to stop eating. And sure, maybe the scale hasn't changed, but that change in how they perceive their food or how they're able to intake, or just the relaxation of the stress behind food choices actually is helping the patient. So perhaps at this point, and maybe we add on a second agent. So we actually do combination therapy, which we would also do for any other chronic disease, such as treatment of hypertension. Not too many people with high blood pressure are only on one single agent. So when we look at anti-obesity pharmacotherapy, again, there's some key messages here. There's a chronicity of being on a medication if it works for an individual. Started as a trial, try to get at least 3 months of maximum dose tolerated. It should be used with structured lifestyle changes. And I'm going to show you the beauty of putting it all together with good behavioral programs. And then there's a difference also for some patients with respect to these anti-obesity medications. Let's say they've lost quite a bit of weight through some type of intervention, a lifestyle change, but now those hunger signals that are starting to pop up. Well, we add on pharmacotherapy, they don't lose any more weight, but they're maintaining it off. And so that's a win too. The use of pharmacotherapy, not just for weight loss, but also for weight maintenance. And then let's not forget the following. We have this group of patients that are super responders, and then we have those that are non-responders. And the super responders, we are super happy for. It doesn't take a lot for them to lose a lot of weight. But the non-responders are a difficult group because they're a phenotype that obviously we haven't found the right treatment for yet. And it can be a frustrating experience, but it's important again to tell them that it's not their fault. We are going to keep on working on a potential other treatment option that we can address. This is a great New England Journal article if you have a chance to pull this. It was sometime in 2017. You can see here the reference. I love it because it's still very valid and it goes through the different mechanisms and pathophysiology and management of obesity. And it actually has this chart where it isn't a direct comparison. I just have to, there's no RCT directly comparing all of these different pharmacotherapies, but it's basically summarizing the studies involved with that specific agent. And it shows the greater than 10% or greater than 5% categorical weight loss that could be achieved with these medications. And so highlighting orlistat, liraglutide, and then in our world, naltrexone, that's bupropion, you can see the rates of greater than 10% weight loss or greater than 5% weight loss. And so here we have liraglutide, where 65% seem to at least achieve a greater than 5% weight loss, and up to 35% greater than a 10% weight loss. But what I particularly like about this table is the following. It actually compares to lifestyle intervention groups where it's high intensity. And here we have that look ahead study. So thinking again, here's the 3 medications, and here's the look ahead study, which had pretty much no pharmacotherapy, but a great program, partial meal replacement strategy. And you can see it, wow, it did pretty well too. In a group of people with diabetes, where typically with diabetes, we don't see as much weight loss. So it begs the question, what if we could do it all? What if we could have a great program and the addition of pharmacotherapy? And I love this study because it actually shows that here we go. We have this group in red who did a lifestyle intervention group. Then we have here in yellow, they did the lifestyle intervention with liraglutide. And here in blue, we actually have the lifestyle intervention with liraglutide and the use of a partial meal replacement strategy. And you can see that actually there's an additive impact with those behavioral strategies and pharmacotherapy. Now, the obvious question is, what the heck happened here? How come the curve starts stopping and then it starts going back up? It's because around this period of time, the role of meal replacement stopped because eventually it was free for a while, right? You can't get free food forever. And people went back to a food-focused regimen and weight started going back up and hitting about the mark of what you would have had without meal replacement. So I bring this up because you can see the additive impact of different treatment options combined to help a patient. Now, we all know that there's a new agent, semaglutide, and there have been a number of studies that have been published recently, the STEP series, and the results are very, very exciting. And so many of you probably already know that semaglutide, and this is just one study showing the placebo group as opposed to those who are on semaglutide 2.4 milligrams, you can see that, in fact, there's at least a 10.3% difference in body weight change as compared to the placebo group. So this is the semaglutide group, and here is the placebo group. So very exciting. Now, the other exciting thing is the line of this curve, because typically when we look at anti-obesity medication trials, we'll see that nadir or plateau start occurring at the 6-month mark. But in this case, we can kind of see it just starting to plateau here at the 1-year mark before we start seeing that curve maybe start heading upwards again. So exciting. Not only are we losing maybe higher percent weight loss, but that curve is pushed out further over the months. Looking at the categorical data, very exciting too. We see that almost a third of patients lose greater than 20% of their weight. Amazing, because here we are starting to approach surgical results. Now, this medication, I do want to emphasize the following. Okay? It works just like liraglutide at essentially blunting hunger signals. And when you will be prescribing this medication, and myself too, I think it's important to acknowledge the following, is that having no hunger is not necessarily a good thing. And I see it time and time again when patients may be just randomly prescribed an anti-obesity medication that impacts hunger signals, and they don't necessarily follow through with the clinician, and they go off doing their own thing. What happens without proper guidance and good nutritional therapy, many patients start to undereat. They actually view it as a good thing. And they start losing more muscle mass because they're not getting enough nutrition. Not only, but you know what? They'll report to you and see you several months later and say, hey, I lost all this weight. Oh, great, how do you feel? Well, you know, I'm really tired and I'm feeling weak and a bit dizzy, but you know what? I lost 50 pounds. I feel great about that. But quality of life necessarily is not the best. So it's important that we follow our patients very carefully if we do prescribe anti-obesity medications, because again, it's not about the number on the scale. It's about making sure that they're healthy. A few words about bariatric surgery, because I know you will have a whole session about that. So bariatric surgery, there are different bariatric surgical procedures. Many of you already know about the Roux-en-Y, about the lap band, the sleeve, the duodenal switch. Essentially, for instance, with the Roux-en-Y and duodenal switch, which includes a malabsorptive component with the surgery, as you bypass a tract of the small intestine, the more you have a bypass of a tract of small intestine, the more likely there's potential risks such as nutrient deficiencies. So on the other hand, though, those are the procedures that have the most potential of keeping weight off long-term. I know there's questions. I'm going to actually talk about questions after the talk, just because it's very hard for me to manage the screen and answer questions. But what I do want to point out is the following, is that the lap band, at least in Canada, is viewed very badly now. No surgeon really wants to do it. It's had a number of complications and a number of patients are having it pulled out. So the lap band is not something that's being viewed. I'm not going to go further details into the surgery other than in our guidelines, we do say that those who qualify for bariatric surgery includes those with class 3 obesity, class 2 obesity with comorbidities, and new in our guidelines is class 1 obesity with, for instance, uncontrolled diabetes. Now, that being said, let's think of the following. Bariatric surgery is a tool to help treat excess weight in a patient, but it doesn't fix everything. And so we really need to make sure that our patients who undergo the process of wanting to have bariatric surgery are ready for it, are ready for the health behavioral changes that need to occur in order to support working with that tool. And that includes having regular meals, good quality nutrition, good protein intake, taking a handful of vitamins every day for the rest of their life, separating their liquids from their solids, not be a smoker, minimize alcohol, no caffeinated beverages, no bubbly drinks, no pop, because any of those factors can actually cause harm to the lining of the stomach or of the attachments and hence cause future harm for the patient. So if your patient approaches you about bariatric surgery as it's going to fix me attitude, be careful about that, because it's not going to fix that person. It's going to still require a lot of hard work. And so now I come to that pillar of the psychological intervention, which ultimately I think is the most important part of the pillars. It plays a role not only just to hold up that roof of medical nutrition therapy and physical activity, but it also plays a balance here with the other pillars. So we're going to spend a bit of time about what does that mean, that behavioral pillar. Again, there are chapters related to this in the guidelines, and what I'm trying to do is bring out the essence of this so that can help you put into context all of these chapters. So a shift in paradigm with our view of obesity is really the role of the brain in all of this. You know, often enough we think, oh, it's a gut issue. It's right how much you eat and so on and how much is absorbed. But really the brain plays a large role in obesity. And so what if we were to partition our brain into 3 sections? Okay? We have that homeostatic part of our brain, and we talked about those hormones that impact hunger signals. We have that hedonistic component of that brain, about the wanting and liking of food. Think about it. The last time you might have had a great meal and you're actually completely full, but then dessert comes out. And you're like, oh, why not? I'll have that piece of chocolate cake, right? Even though you're not hungry. And then there's that executive function of our brain, that prefrontal cortex, which is extremely important to help manage our behaviors. So those are the 3 parts of the brain, but let's divide it further. Let's think about the homeostatic and hedonistic component of our brain as our caveman brain. The caveman brain is actually our natural programming for survival. It's the caveman who centuries and centuries ago basically just wants to survive, needs to eat high caloric dense food because you just don't know when your next meal is, needs to hunker down and relax and preserve energy because if that wild animal shows around the corner, you have to be ready to just run. And that is our caveman brain that is always on, that is always trying to help us survive. And then we have our executive brain, which is there and has to be turned on. It has to be turned on to overcome our caveman brain. It's there that we can help our patients build skill sets to overcome that caveman portion of our brain. How often do you have a patient come up to you and say, I know what to do, doc, or I know what to do, but I just don't do it. And the question then is, how do I, as a clinician, help my patient choose the carrot instead of the carrot cake? What is it that I can do? Why is it so hard? And explaining this to a patient can be really helpful because essentially our caveman brain is always going to go for that carrot cake. And it's our executive brain that we need to turn on to choose the carrot. And it's not easy. Let's face it. Healthy habits are hard. Why? Because to be healthy, I essentially have to avoid pleasure. I really shouldn't have that piece of chocolate. I should actually, have an apple instead. I should accept pain. I actually should probably, instead of sitting in front of the couch and watching TV, I should go out for a walk or a run. I have to do the things that take the most amount of effort. Now I have to take the stairs instead of the escalator. And I have to do this for the future that is a little bit of an unknown versus the present where I could just have a few moments of relaxation, pleasure, but ultimately it's not taking me in the direction that I was hoping for from a health perspective. Now, I'm going to bring in here the concept of weight bias, and you'll see why it's so important from a health behavior perspective. Again, there's an excellent chapter on weight bias in the Canadian guidelines, and I do encourage you to take a look at that one because it's quite unique to any guidelines known internationally. So there are 3 types of weight bias. One that is pretty obvious, and it's called explicit weight bias. And so many of us are familiar with the fat shaming commercials or things that you see in the newspaper or bad terminologies from movies, TV, etc. Okay? But here's another aspect about explicit weight bias. It's our own medical terminology. And notice throughout this whole talk, I have qualified people living with obesity, not obese people or morbid obesity, which is often what is documented in health documents. And imagine, especially nowadays, as patients get more access to their charts, etc., how hurtful it is to see this morbidly obese person showed up at my clinic for knee pain. They obviously need to lose weight in order to not have knee pain. They have to basically eat less and move more. Ooh, okay. So terminology is important. And so remember this, obesity is a disease. It does not define a patient. Therefore, in our medical documents, in the way we talk, it is a person living with obesity or a person with obesity, not the adjective of obese person. Implicit weight bias is a little bit less obvious, but thinking about it as a clinician and as you build your practice for managing people living with excess weight, think about your own clinic and whether or not it has the appropriate unbiased surroundings. For instance, do your chairs accept a higher level of weight? In our office, our chairs can go from 700 pounds to 1,000 pounds. Our examination table takes up to 1,000 pounds. Our scales go up beyond 500, 600 pounds. These are important things because nothing is more embarrassing than a patient shows up and cannot fit into your medical equipment. Think about your blood pressure cuff. Do you have different sizes? Do you have an extra large cuff that actually doesn't have the word thigh on it? So embarrassing for a patient to have a blood pressure cuff strapped on that has the word thigh on it. Can we provide a safe, comfortable, unbiased environment for our patients to feel comfortable discussing their weight? And then let's talk about internalized weight bias, which is probably not as well recognized, but plays a huge role in behavior change. And essentially, it's the extent to which people living with obesity actually do negative self-talk. It actually seems to me that some of the worst fat shamers that I know are actually the people who are living with obesity. They say terrible things about themselves. And so we as clinicians need to work with those patients to take away that shame of and that internalized weight bias that they live through. Here's this slide. If you had a thought you were a unicorn, would you believe it? So why do you believe it when you have a thought that you're ugly or stupid or crazy or unlovable? And the words can be, I'm fat and I deserve it. I hate myself. Why do I keep on failing? Well, because you know what? You have a chronic disease and we need to find out what are the behaviors, what are the tools that could be supportive for you. This is not your fault. Now, how do you address obesity in your practice? And this may have already been touched on by Dr. Al-Karousi. But it is key in the Canadian obesity guidelines, which is the 5 A's concept. Okay? And basically the 5 A's is an approach to managing obesity, which is you start with ask, assess, advise, agree, and assist on treatment options for a patient. It's a very simple algorithm, but I'm going to tell you the following. As clinicians, we are pretty good at the assess, advise, agree, and assist. We do that with all different kind of chronic diseases. What we're not necessarily good about is that ask, that first A, which is the most important. Now, if you are a clinician who purely does obesity management, then your patients that are coming in already know why they're there. But let's say you're a clinician who has a diverse practice and you're starting to think of doing obesity management. Then the question is, how do you start, right? And that ask question is extremely important because you can imagine patients living with obesity are supremely damaged. They've gone through healthcare systems, different diets, commercial programs, whatever it is, and they're coming in with that internalized weight bias, and they feel awful about themselves. And if you don't approach this in a permission type of way, would it be all right if we discussed your weight? Would you be interested in addressing your weight at this time? Putting that hand out and that question in a gentle, really just earnest manner can do a lot towards mitigating that self-bias that a lot of patients will internalize. And so I know you will all have a chance to work with Dr. Lee Bagley about behavior therapy and going through some cases. I do think every chapter that has about the psychological interventions and so on, you'll see they talk about motivational interviewing, mindfulness, cognitive behavioral therapy, and a form of cognitive behavioral therapy called ACT, which is acceptance and commitment therapy, based on values-based behavioral change. And I will say I find ACT as a philosophy and treatment option and a stance that you can take for your patient, very forgiving and a nice way to approach working on changes in behavior for your patient. Essentially charging that executive brain, overcoming that caveman brain that's always on. And so what does ACT mean? It means really exploring the values of a patient. What is it that's going to continue to motivate a person to move forward in those health behaviors that are not necessarily easy? Often patients might be saying, what's the matter with me? Like, why can't I do it? But you flip that question into what matters to me? Why am I going to do all this hard work? And often enough, patients will say, well, I just want to be healthy. But we can actually push that question a bit more. What are you going to do with those extra health years? Wow, well, I would travel. Oh, yeah, there's a sense of adventure there. Oh my gosh, I could actually spend more time with my grandchildren because I'll have more energy and be more flexible. And so family is important to them. And so when it's the end of the day of a hard work and that piece of carrot cake is calling you versus having a carrot, I have to think back to my values. Why am I doing all this hard work? I'm doing this for my family. I'm doing this for a sense of adventure. And because of that, I am now going to have that carrot. So the final concept I'm going to bring out here with respect to behaviors or goal setting is that we as a clinician towards the end of every visit should have some type of behavioral goal for our patient. And it really shouldn't be about the number. Okay? Tell me what is more easier to do if I told a patient this. Today, your weight's 300 pounds. Tomorrow, you will weigh 250. And the day after, you will weigh 180 pounds. Or is it better to go through the following and more realistic? Today, you will have a breakfast. Tomorrow, you will go for a walk. And the day after, you'll go to bed earlier. Which one is more doable? And this shows the concept that we do not control the number of the scale. We just can't predict it, but we can control our behaviors. And remember that whole spaghetti plot I showed you at the very beginning of this talk, and that little red circle of what we can control, that's what we can control. And this is how we can guide and coach our patients. A behavior also could be things like, I'm going to call my insurance to see if a medication is covered. It could be a behavior of just actually taking a medication. How many of us know of patients who are not necessarily compliant with taking any type of medication? It is, again, an exploration of why would they want to do that? What are the values behind it to drive setting those behaviors? We talk about trying to achieve a 90% behavioral goal, a goal that you're 90% confident that you can do. Other ways of viewing this, like in motivational interviewing, is how confident are you to do a behavior? 0 out of 10, 10 being super confident, 0 not. Oh, I'm like 5. Well, what would it take to move you from a 5 to a 7? You know, these are the kind of coaching skill sets that you can do to help your patients take control of health behaviors. And the more we can make these SMART goals, specific, motivated by values, adaptive, realistic, and time frame, the more likely we're able to get them forward in their journey. So essentially today, what I've presented is addressing that care gap that exists. You know, there is that care gap between how a patient views weight and how a clinician views weight. I think our Canadian guidelines actually tries to bring this together by having not only messaging for clinicians, but also for patients. And I invite you to take a look at those chapters, thinking back to what I've discussed as global concepts. There's also always that care gap of doing guidelines and then having them implemented or even read. So that's another gap. But remember this, the basic information I provided you today about our guidelines is the following. Obesity is a chronic disease. There are a number of factors that are not within our control. We can control our behaviors. It's important to mitigate weight bias in all of its forms that exist with obesity. And we now have this new paradigm shift of how the brain is such an important role in obesity, but also in our treatment options, where we have 3 pillars: behavioral support, pharmacotherapy, and bariatric surgery, that holds up that roof of medical nutrition therapy and activity that our patients have to continue in order to manage their weight. So thank you very much. I view this as a partnership, an international partnership, for the greater good of the most prevalent chronic disease that exists in our world.
Thank you very much, Dr. Shao. Such a beautiful, comprehensive talk. You covered everything on obesity management from A to Z. I'm waiting for my video to start. 1 second.
Oh, I think I just lost that question. So sorry. Oh, here it is.
I can read the questions if you want.
I see it.
Yeah.
What is the safety profile of semaglutide? Who would be the ideal candidate for this drug? So that's excellent. You know, I think basically the safety profile, you probably have semaglutide available in the 1 milligram format. Do you, Dr. Alcomsi?
We are switching you mean to, semaglutide, you don't have the 1 milligram yet, but we are switching from liraglutide 1.2 semaglutide, hopefully in the near future.
Yeah. So if you've got a familiarity with liraglutide, it's very much the same safety profile. I think the beauty of it is the injection is just once a week, okay? Which, boy, that's a game changer for some patients. Now, then again, you have to make sure that your patients are going to remember to take it once a week as opposed to daily. But it does have its GI side effects, and there is the risk of still pancreatitis and gallstones that exist. In the higher dosage as compared to 1 milligram, I don't think that safety profile is any worse. In terms of our guidelines, I'm not sure how it's going to change that flow chart that I showed that is currently published in the pharmacotherapy section of our guidelines. I know that it will be integrated at some point, but right now in Canada, the semaglutide 2.4 is not yet approved. So until it's approved, that flow chart isn't going to change yet.
So I was going to ask you if actually you ask patients to increase the dose on the 1 milligram that you are using. already?
Yeah, we have like, so us as a group, we try to keep to not being off label for multiple reasons. Part of it has to do with also coverage of these medications. And if you push it beyond what's currently approved, you're actually committing insurance fraud. So that's one thing we're not trying to do. Number two is, again, the safety profile of it. Yes, it's safe, but God forbid you push someone beyond the 1 milligram and they have pancreatitis and die. That would be horrible. And I have lived through, you know, we talk about bias against patients living with obesity. There is a huge bias about medications for weight management, even from patients themselves. And it doesn't take much for any of the health agencies to pull a medication off the market. And I have lived through that for at least one agent, that was Meridia. And thankfully I kept it on label, but if had I been off label, that would have been a disaster in terms of the number of letters I would have to write to patients. So especially when semaglutide is so close to being approved in Canada, we don't do off label usage because we don't want to have that incident occur where someone reports a bad incident and then that medication doesn't arrive in Canada.
Exactly. So the other thing you talked about is like using naltrexone and Wellbutrin like a separate prescription. We don't have oral naltrexone. I tried that. Unfortunately, we don't have it. But I know that, yeah. So, I think there is like a process to approve it by the Ministry of Health for Contrave or propropion and naltrexone combination. So one of the questions that I received was, what are the out prescription medication available in Oman? So what we have is right now is liraglutide, the 3 milligram, which is Saxenda. We have it as an outside prescription, and we have also Orlistat or Xenical as also outside prescription. So this is one of the questions that we had from one of the participants. How to manage the GI side effects with GLP-1 agonists is another question. A lot of patients are stopping them due to intolerance despite good response.
Right. So so let's talk about liraglutide because that's what you have right now. And so number one is make sure your patient is eating. Okay? I do find again that patients, when they start the medication, they're like, oh my God, I'm not hungry, and they don't eat. The nausea gets worse, right? They actually are not like that gastric emptying is slowed down, compounded with not having food. Then they really get sick. So that's number one. So make sure they have structured nutrition. Okay? Number two is the beauty of at least liraglutide 3.0 is that you can click and you can adjust the dosage. So it goes, when you're increasing a dosage to 3 milligrams, you start at 0.6 milligrams per week, then 1.2 milligrams per week, then 1.8, then 2.4, then finally 3 milligrams. So every week you increase. But there's actually 10 clicks between every increment of 0.6. So let's say you start off at 0.6 milligrams and a patient's like, yeah, a little nauseous, is not too bad. And then they go to 1.2 and they're throwing up. They're like terribly sick. Counsel them before they even start the medication that if something like that should occur, they go back to the lower dosage, stay there until they feel stable. And then if they want, instead of going 10 clicks all the way to the next dose, they can do 2 or 3 clicks, try that for a few days and slowly ramp up. And perhaps they'll reach a sweet point. And here's the other thing. You know, some patients think, I have to get to 3 milligrams. I have to get to 3 milligrams. I'll do anything to get to 3 milligrams. But you can say to them, actually, no, there are some patients where it doesn't take much. And if they can hit that sweet point where it's helping their appetite management, helping weight, but not making them sick, so they have quality of life, then just stay there.
Thank you very much, Dr. Xiao. I really love the switch from the pyramid to the pillars. It's really nice touch from the guidelines. And I recommend everyone to read the 19 chapters from the guidelines. I already attached them for everyone in the Google Drive to go through. That was a really excellent talk. I don't think we have more questions at this time. Thank you very much. And we will wait for Danielle in 1 hour. I think we will get back to Danielle to start the dietary intervention as well.
Okay, well, thank you so much for inviting me.
Thank you very much, Dr. Xiao. Bye. So Danielle, we will break for 1 hour, and you can
Sounds good.
actually try share your screen and put it at the front until we come back. We just check the screen sharing.
Yeah, just now we'll try. Yeah.
Very good. Excellent. I
Let's
think you
try.
can see the shared screen.
You can see or cannot see?
We can. We can.
Okay, perfect. I'll just advance a couple just to make sure that I didn't put much, animations or anything in there. It's pretty static. So,
Excellent.
and it's
Very
about 45 minutes with questions to follow is what we're planning for, Amira.
exactly.
Perfect.
Okay. See you in an hour.
Excellent. Take care.
Bye. Where did it go? That's in Q&A. So the question was, what is food addiction scale? So food addiction scale is basically one of the questionnaires that we use to diagnose patients for food addiction. And the only scale I know is the Yale scale. I think it was from 1998, right, Danielle? Correct me if I'm mistaken. So so this is the only food addiction scale that I know. You can find it also online. And then can you explain more about Edmonton obesity staging system? It's a staging system developed by Dr. Arya Sharma from Edmonton and Alberta, I think, University. And the staging system goes from like 0, where the patient has no comorbidities related to obesity, to stage 1, 2, and 3 for being palliative. So it's only kind of a classification you use for your patients if you want, like what class of obesity they are and what Edmonton stage they are. And then basically you can classify those patients and then address management based on that if you want. But it's only just a classification system. The other question is, what is age appropriate cancer screening? So it depends on, to be honest, I'm not completely aware of the protocol that we use for screening in Oman, but generally it is for example, colonoscopy or mammogram or pap smear, and it depending on the age of the patients, like because a family physician usually does the screening. So it depends on the age that you start screening the patients, whether they are age above 65, you send them for colonoscopy, or mammogram for women above the age of 45, and so on. And so this is what is known about like age appropriate screening. Like we have a system here in Oman, but I'm not like the detailed screening program in Oman, I'm not sure of. So you can we can discuss this maybe in the next session when we talk about pre-bariatric evaluation, because one of the things that is required is actually age appropriate screening. So that is the last question. So I think we start in 4 minutes. Another question. It is 7 p.m. in Oman, so the time difference is still more.
Yeah, it's 11 a.m. on a beautiful Sunday morning here in Ottawa.
Exactly. Okay, so we have reached 41.
You just let me know, Amira, when you'd like me to start.
Sure. We can start. No.
And hopefully just let me know. I'm getting a little bit of glitchiness coming through, but if I'm not coming through clearly, please let me know.
Sure. I think it is from my side when I turn
Okay.
on my video. So I'll just close it like when you start, but you are very clear. Like
Perfect.
you're out perfectly.
So shall we begin?
Yes, go ahead.
Perfect. Thank you very much for inviting me to speak on nutrition approaches to the care of the individual living with obesity. My name is Danielle Aldis, and I have been a registered dietitian for just over 20 years. I hold a certified bariatric educator status, and I'm also a certified diabetes educator. Most of my career has been involved working with individuals. I apologize, my dog is just about to go out on a walk and is very excited. Living with chronic health conditions, including heart disease, diabetes, and obesity. Although when I began working as a dietitian, obesity was not viewed as such. So I'm so pleased that we're beginning to better understand the complex nature of body weight and appetite regulation and treat people who live with obesity with greater respect and a better set of tools, self-care tools, medical tools, and surgical tools that go well beyond the unhelpful and often stigmatizing advice of eat less and move more. I'm aware that earlier this morning you had some excellent presentations, and for sure with Dr. Xiao's discussion, we are understanding that obesity care involves setting up your environment for success. We have moved from viewing lifestyle strategies as the foundation on which treatments are built to viewing them as the key protective elements that form the roof that shelters from the storm of health complications that are related to obesity. So this structure is supported by the psychology and mindset pillar, the medication and pharmacotherapy pillar, and certainly the surgery pillar as well. But healthy eating, activity, and sleep are key self-care actions that individuals can commit to improve their health overall and can have impacts on their weight. And so I'm going to discuss in this presentation the nutrition elements that contribute to this protective roof that needs to be in place to make the most of all other interventions. So throughout this presentation, I'm referencing in large part to the Canadian Adult Obesity Clinical Practice Guidelines, and specifically the Medical Nutrition Therapy chapter in obesity management. The key messages in this clinical practice guideline include an emphasis on the fact that there is no one right way to eat when it comes to obesity management. Healthy eating is important for all, regardless of body size, weight, or health status. It's important to use an evidence-based approach in providing patients their nutrition behavior change advice that aligns with their preferences, their available resources such as time, money, cooking skills, and personal values as well. So to that end, medical nutrition therapy interventions should focus on achieving health outcomes for chronic disease risk reduction and quality of life improvements, not just weight changes. So in this particular chapter, if you're curious, table 2 does summarize the health-related outcomes linked to the various nutrition interventions. And I would encourage you to check that out if you'd like more specific details. But medical nutrition therapy interventions should also align with the individual's acceptable and actionable eating patterns. There should be a focus on food quality, not just the quantity of food. So reducing ultra-processed foods and focusing on unprocessed and minimally processed foods is key This ensures that we are focusing on nutrient-dense foods. And definitely building a focus on how and why we eat, not just how much we're eating and what we're eating. So slowing down, being mindful of hunger and fullness cues, and considering strategies to nurture rather than nourish when our hunger is not about true hunger, but a situational or emotional appetite. So I want to introduce you to Amanda, and I'm going to occasionally use Amanda as a case example of how to apply the nutrition assessment process that I'm describing in the medical nutrition therapy approach, and highlight the clinical implications in making collaborative decisions when building the MNT prescription. So Amanda is a 32-year-old woman who was referred to our clinic for help in addressing her weight, and she was interested in nutrition and medication therapies. She stands 167.6 centimeters in height, or 5'6". She weighs, at the time that we first met her, a self-reported weight of 265. We are under a lot of virtual care still here in Ottawa, so we are relying on self-reported weights at this time, which gives her a body mass index of 42.8. She is a retail pharmacist. She used to play rugby and has some significant knee injuries, which have been surgically intervened on. She has been off work during the pandemic because her son was born 19 months ago, her first child. She had lost weight pre-pregnancy, but she did experience weight regain during the pandemic. So elements of the medical nutrition therapy that I'm going to walk through in this presentation include estimating energy needs and understanding how we come to an energy prescription, to look at the impact of caloric restriction and the various variables that are involved with determining what caloric restriction or energy deficit prescription might be appropriate, the macronutrient recommendations, so digging into how within your energy prescription we swing the carbohydrate versus fat versus protein. Then take a look at meal pattern approaches, meal replacements, a little bit about timing, so comparing fasting variations to continuous calorie restriction, a little bit around feeding our microbiome, essentially a whole new organ really that we are considering when it comes to obesity management. And finishing off with a bit around the micronutrient recommendations that are included in the Canadian practice guidelines. And I'll say here that these may vary based on where you are in the world, because certainly when we get there, you'll see vitamin D is one that's key, but that is, it's geographic in nature. And so it may be different in your part of the world. So let's start with estimating energy needs. So total energy needs include your resting energy expenditure, which is the largest part of this pie here in blue. The thermic effect of food, so essentially the energy we expend when we are digesting our foods. A component known as adaptive thermogenesis, so this is the energy we expend to regulate our body temperatures, and the physical activity expenditure, what we are doing in moving about our day, whether that is in purposeful exercise or just the activities of daily living. The best way to know what somebody's energy needs are is to conduct a direct measurement of that. But in the absence of a tool that will allow you to do indirect calorimetry, which we do not have in our clinic, we need to estimate the energy needs for weight maintenance and then calculate an energy deficit if we are working to promote weight loss. And the Mifflin-Saint-Jeor equation is one of many available predictive equations, but it has been found to be the most reliable at predicting resting energy expenditure or resting metabolic rate within 10% of measured values in lean individuals and individuals living with obesity. And it's thought to be better than any other equation in the overweight population, and it also has the narrowest error range. And there is some reference I can make available around the comparison of these predictive equations for resting metabolic rate, if you wish. So applying the Mifflin-Saint-Jeor, there is a equation for men and an equation for women, which varies in terms of the coefficient of age. And so if we are applying this to Amanda in particular, we would use her weight in kilograms, her height in centimeters, and her age, which is 38. And that would give us a resting metabolic rate for Amanda of just over 1900 calories. We then have to consider her total energy expenditure, because this resting is representing probably 70 to 80% of her needs, but not 100% of her needs. So we are going to look at adding on an activity coefficient, multiplying her resting energy expenditure by an activity coefficient. And for her, she's very active at work. She works in a pharmacy dispensary, a retail pharmacy dispensary, where she's on her feet on the go all the time and lightly active at home with her almost 20-month-old son. So we would apply for her about a 1.6 activity factor for a moderate activity, and that gives us just over 3,000 calories for her total energy expenditure. So this is her estimated needs to cover her with neither a gain nor a loss, so to keep her in balance. And there are standard physical activity coefficients, and in Canada, these have been incorporated as part of our dietary reference intake tables. And so if you're looking for more information on what numbers to choose for activity levels, that's where I typically reference those in the DRI data. What's interesting though is just last month, there was an article released in Science. So this is a little bit of an aside, but Mifflin-Saint-Jeor and other predictive equations account for a continuous decline in resting energy expenditure during adulthood. So there is that coefficient of age that is incorporated into the prediction. But recent evidence does suggest that age-related declines in energy expenditure may be more stepwise than continuous. So changes in body weight in the decades between the ages of 20 years and 60 years may not be related to declining energy expenditure to the degree that has been assumed. So measurements of total and basal energy in a large cohort of subjects at ages spanning from before birth to elderly age showed a distinct change that occurs over that lifetime, but that tissue metabolism appears not to be constant, but rather to undergo transitions at some key critical junctures. So whether or not we need to incorporate this into our predictive equations, again, this is a science that's always evolving, and it's just another example of how that is. A really elegant and easy to use tool that if you or your patients are interested in taking a deeper dive or getting away from those complex predictive equations and being able to step through a body weight planning or an estimated energy reference is the Body Weight Planner by the National Institute of Health. So it's an excellent online tool to be used by both clinicians and patients. One of the key scientists behind this is a man named Kevin Hall, who I'll mention in relation to another study in this presentation too. His team have based this tool on some very sophisticated dynamic modeling of the physiology and physics of weight loss. And this tool really moves us away from the classic 3,500 calorie rule, which is the rule that said 3,500 calories of energy stored in 1 pound of body fat. So if you're looking to tap into or burn off 1 pound of body fat, you would look to reduce your energy intake by 3,500 calories over a week, or over whatever duration you're trying to lose that pound of fat, and divided by the number of days that you are doing that. So that is often where we had come to the 500 calories less per day. But that doesn't really hold up to our understanding of the physiology the neurohormonal complexities of weight regulation. So when we are creating an energy deficit prescription to instigate some weight loss, we do though still tend to take our total energy expenditure, and we're looking to reduce that by somewhere between 500 to 1,000 calories daily, because we have seen that this can correlate to a 5 to 10% weight loss. And in obesity management, as well as cardiorespiratory fitness, it's critically important in improving the overall cardiovascular health of people who have overweight and obesity. So obesity management benefits all patients with obesity, regardless of the amount of weight loss. But we can see that patients who are able to achieve a loss of 5 to 10% of their initial weight will experience a reduction in their cardiovascular disease risk factors. So improvements in lipid profiles, reductions in blood glucose and hemoglobin A1C, and typically a decreased risk for developing type 2 diabetes and other obesity-related complications. So 5 to 10% weight loss is a key target when we're talking about lifestyle interventions. So we can see that a lowering of blood pressure, reduced cancer risk, particularly breast cancer, as mentioned, the blood glucose improvements, lipids, joint musculoskeletal ailments and joint pain, reduction in liver enzymes, quality of sleep. So many benefits can come from achieving a 5 to 10% total body weight loss. So if we take Amanda's case, and rather than attempting to do this in a dynamic way as we're here in this presentation, I've gone in and I've walked through the steps in the body weight planner using Amanda's age, gender, height, and current weight, starting weight. And I've set it to a 10% loss. The simulation here is showing for 365 days, but the body weight planner will ask you, you can adjust the number of days over which you are doing the modeling, and typically it is set for a 6-month period or 180 days. So using the tool in the goal weight mode, and Amanda's figures targeting a 10% loss over 180 days, where we are starting with 265 pounds, then our target weight in that duration is about 238 pounds. So you can see 239. That is at the 365 day mark. But if we're looking at her trajectory, sort of the low peak here at 180 days is about that 238 pounds. So the estimated deficit to achieve this, you'll notice, is the difference between Amanda's estimated energy needs. So if you recall using our Mifflin-Saint-Jeor equation, she was estimated to need about just over 3,000. Here, the estimate is about 3,200. You will see this, that various models will give you slightly different estimates. But to reach her goal in that 180 days, we've got about an 800 calorie deficit here in that weight loss phase. And then to maintain her goal weight, this plan does predict that she would need to come back to balance, but that her new balance, you'll notice, is about 200 calories less than what it was at the start. So you do need to maintain an energy deficit in order to maintain a reduced body weight. The other way to go at energy deficit is to look at applying a standard caloric reduction. And so in the medical nutrition therapy chapter, it talks about some standard energy deficit and caloric restriction parameters. So common energy prescriptions include the moderate energy prescription, which would say that regardless of what your estimated energy needs are, that we're looking to apply a 1,300 to 1,500 calorie per day prescription to achieve a weight loss. Low calorie prescriptions are defined as between 900 and 1,200 calories per day, and very low is defined as under 900 calories per day. A little caution here, though, is that 1,000 calories, if you're prescribing 1,000 calories per day or less, Consider what the total energy the total energy needs of the client are, and how far below those total energy needs your 1,000 calorie prescription is. So a randomized control study of women between the ages of 25 and 75, and this is detailed in the medical nutrition therapy chapter, with obesity class, Edmonton obesity stage class 2 or 3. Obesity class stage 2 or 3. So these were individuals with body mass index over 35, found greater weight loss at 6 months with a 1,000 calorie nutrition prescription rather than 1,500 calories, and more who were retaining or maintaining a weight loss of 5% from baseline, so 5% total weight loss or more, sustained at the 12 months mark. However, there was significant weight regain in the 100,000 calorie group. So even though total weight loss was still at 5%, they had been lower and were experiencing a regain versus the 1,500 calorie group at 12 months. So 1,000 calorie per day prescription may be more difficult to sustain, especially for those for whom the prescription is 50% or more below their usual intake. So again, if we were applying this to Amanda, we can actually use the body weight planner tool targeting it based on a specific calorie reduction. So going into the body weight planner, rather than using the goal weight mode, we can actually do it based on a lifestyle change mode. And so we can put into the planner, and my highlight may have kind of skewed that a little bit rather than pointing it out nicer. So this change would be for Amanda, we're looking to apply a 1,500 calorie nutrition prescription and look at what that is going to do for her over, again, the length of simulation here we're doing is 12 months or 365 days. So when we do this, we see a significant decrease in weight, and we're sort of getting into that range, predicted a final weight of 166 pounds. Interestingly, this is approaching Amanda's all-time low weight in her life. She reported, mid 160s as her all-time low weight in her late teens, early adulthood. So in this case, this 1,500 calories, though, is less than 50% of Amanda's estimated total energy expenditure, which we had predicted somewhere between 3,000 and 3,200 calories based on these two methods. And so there is caution to ensure that she's able to sustain this. And when we look at that 165 pound weight out at the 365 day mark, this represents a 37% change in body weight from her baseline coming into the clinic. So she came in at 265 pounds. This is predicting a weight of 166. So just putting that into context, most lifestyle interventions achieve a 3 to 6%, or we will sometimes quote that 5 to 10%, but in reality, when you crunch the numbers, most purely lifestyle interventions tend to be somewhere around the 6-7%. Look Ahead was looking at about an 8% sustained weight loss, but that also used partial meal replacement. So without meal replacements or medications, 3 to 6% is probably what we can expect. 30% total weight loss is more consistent with outcomes from surgical interventions. So helping clients understand weight outcomes is really important because we all have high expectations of change, and we know that there's going to be some significant forces at play as this weight is trajecting down. Not all of those will be under Amanda's control. And so it's important to talk about how low can you go and how long can you sustain that. So caloric restriction does achieve short-term weight reduction, and most studies look at that over a 6-month, 12-month duration. Our longest one that has looked at that is Look Ahead, so looking out 8 years and identifying what happened with individuals and looking at their weight losses that far out from the intervention. So as weight goes down, we do know that short-term hunger signals increase. So those hunger signals coming from our digestive tract, like GLP-1, PYY, and that whole host of short-term energy regulator signals, but also the long-term energy regulators like leptin in particular, adiponectin as well. These tend to decrease. So our short-term hunger signals increase, our ghrelin is increasing, our short-term fullness signals decrease, GLP-1 and so on, shifting us towards being overall more hungry. Our long-term energy regulators decrease as well, again, enhancing that I'm hungry sensation. And our mesolimbic regions become more heightened to food cues. So in the brain, central regions of the brain itself, we are more stimulated to be attentive to food, and particularly calorically dense foods. So all of which drives an increased appetite, increased ingestive behaviors, and weight regain. So shifting from energy into where our energy comes from, this is really the connection to our macronutrients. So our energy or calories coming from our eating, from our diet, from our foods on our plates can be categorized into 3 key macronutrients: carbohydrate, protein, and fat. And of course, when we're talking to our patients as a dietitian, I'm helping them to understand what are the foods that they are shopping for and preparing that are relating back to those energy nutrients. So our vegetables, fruit, and grain are the key things that give us carbohydrate, but also some protein-rich foods like lentils would fit into both carbohydrate and proteins. Our meat and alternatives, our milk and alternatives are protein-rich foods. Olives, avocados, butters, margarines, these are our fats and oils that contribute fat to our diet. So again, thinking about Amanda, she's going to be asking us questions like, how much do I need? And she's probably been doing all kinds of reading about different types of macronutrient splits. So here's where we're going in these next couple of slides. So she's 38 years old. Again, she's 167.6 centimeters tall. And that would give her, if we're using, we can calculate an ideal body weight, and that's done based on using a BMI of just under 25. So it helps us to understand how much of Amanda's weight is sort of a lean weight or a predicted lean weight versus a excess body fat. So we use the dietary reference intakes in Canada, and those state that 130 grams of carbs per day is the recommended daily allowance for carbohydrate. And along with this, there's what's called an adequate intake of fiber, which is a type of carbohydrate, of 14 grams per 1,000 calories, or roughly 21 grams of fiber if Amanda is persisting with a 1,500 calorie diet. And I'll come back to, exploring that 130 grams of carbs a day. From a protein perspective, it's recommended that we achieve 0.8 grams of protein per kilogram of ideal body weight, which is why when we calculate Amanda's ideal body weight, she works out to just over 70 kilos. So 0.8 grams per kilogram of 70 kilos gives her 56 grams of protein per day is the recommended daily allowance for her protein. There is no defined RDA or AI, adequate intake, for fat in total. There is for some of our essential fats. So omega-6s, we are recommended for a 38-year-old woman to be taking in about 11 grams per day of omega-6 and 1.1 grams per day of omega-3 fats. The DRIs were published in 1997 and replaced previously recommended nutrient intakes that were used specifically in Canada and the US. And they're collaboratively established by Canadian and American scientists through a review process that's overseen by the US National Academies, which is an independent, non-governmental body. The DRIs reflect the current state of scientific knowledge with respect to nutrient requirements and are published as a series of reports by the US National Academies Press. There are references directly through the national academies, and Health Canada also has the DRI tables available on their website if you're looking to dig into some more specifics. So let's take a look at the macronutrient distribution ranges. So again, based on the dietary reference intakes for macronutrients, it's recommended to be eating a meal pattern that provides between 45 and 65% of carbohydrate, between 10 and 35% protein, and between 20 and 35% fat. My neighbor has decided to mow their lawn. Hopefully that's not coming through and distracting too much.
Very good.
Okay, it's distracting me a little bit, so I apologize. So, and again, here within the fats, the numbers I previously mentioned for omega-6s come from the fact that we are encouraged to take in between 5 to 10% of our fat from linoleic acid or omega-6 fatty acids, and between 0.6 and 1.2% of our calories from linolenic or omega-3 acids. So no meaningful advantage of one macronutrient distribution over another has been reliably shown in obesity management. A meta-analysis of 48 randomized controlled trials involving more than 7,200 participants that advised varying macronutrient distributions under free living conditions showed no difference in weight loss at 6 months and 12 months of follow-ups between the various diets. And several subsequent randomized controlled trials have confirmed these findings. So although the takeaway for many people is that diets don't work, when we hear something like that, I look at it differently, and I see that all of them work to a degree. And so ultimately, we want to pick the one that you can stick with over time. The best diet is the one that you can follow, or the best eating pattern is the one that you can adhere to. So no one eating approach has proven most successful, which gives you the flexibility to meet your clients, meet your patients where they are with how they perceive their hunger, their fullness, their satisfaction, their ability to follow any given eating pattern. So this really supports the individualization of medical nutrition therapy delivered by the registered dietitian. So I wanted to just step back for a minute to look at energy nutrients from a slightly different way, because the concept of energy density is really important when we're planning prescriptions for people and helping people to put together healthy eating patterns. So when you understand that carbohydrate and protein have a very similar energy density, so they provide 4 calories for every gram, both of them. These are called the Atwater values, and they help us to look at how much energy is delivered in our foods. Fats provide 9 calories per gram, so they're more than double the energy density of carbohydrate or protein. And back in the days of looking at the low-fat diets, a lot of it was driven by the fact that we thought lots more volume can come from minimizing the amount of fat-rich foods in your eating pattern and maximizing the carbohydrate and protein. And in fact, those low-fat diets actually tended to just emphasize carbs, but didn't look at the quality of them. And so that was a problem. But continuing this on, again, to think, it's important to be able to visualize these things. And we've talked a lot of numbers already. And it's interesting because giving a presentation like this brings me back into some of this core nutrition stuff, but I very rarely talk this level of detailed numbers with clients when we're educating them about how to plan their meals. What we do often illustrate for people to help them visualize this concept of lower energy density eating, because this is what we're aiming for. We're trying to still have lots of bites in our day, lots of meals, lots of food on our plate for volume, but we're trying to make that stretch so we've got more bites per calorie. If we're sticking with a lower calorie budget, we want to make sure we're really getting good mileage out of that. And so, foods that are rich in their water content, water itself, is very low energy density. There's no calories in a glass of water. As we move up the energy density spectrum, we know that fiber and carbohydrates and fiber-rich carbohydrates tend to be lower in their energy density. And truthfully, carbohydrates and protein have a fair bit of overlap in the center here, but proteins are also come along with some embedded fat, if you will. So meats and fish and poultry and soy foods, for example, they're not exclusively protein, they also have a degree of fat. So again, thinking about that spectrum, we have our lowest energy density foods here moving to our highest. And so a way to sort of visualize this a little bit is thinking that, you know, if I was talking about 100 calories, if I'm wanting to consume 100 calories, how much of these different foods would I have to eat to do that? Well, it's 5 cups of cucumber or non-starchy vegetables to give me 100 calories. It's about 2 cups of berries, strawberries in this case. 100 calories would be provided by just 1/3 of a cup of cooked rice. So we're getting much more energy dense here, 1/3 of a cup. Something like our seafood, our fish, our protein-rich food would be about 2 ounces or about 75 grams of fish to give us about 2 sort of bases of your thumb is what we talk about. If we're talking almonds, we're now at about 1/4 of a cup of almonds to give us 100 calories. And when it comes to oils, it's just the tip of your thumb. We often talk about a teaspoon, a little more than a teaspoon of oil to give us 100 calories. So you can see that spectrum overall, we start with a lot and we end up with a little, but it's still 100 calories in each case. So let's highlight a little bit of shifts. If we're talking about keto diet, lots of people come in asking about keto diet, and I understand that in Dr. Amira's clinic, they're using a nutritional ketosis approach. And again, here, we're swinging the macronutrients way towards fat. Fair enough. So we'd still be looking at kind of keeping an energy deficit. We might still be promoting a 1,500 calorie type of approach or something under the total energy needs of the client, but we're moving it towards fat. So a keto diet typically promotes 75% or more of the energy coming from fat. So if we were talking 1,500 calories, that would be about 117 grams of fat. Protein stays moderate, 15% protein or less, like kind of in that range is often common for keto, which means 56 grams. So if this was Amanda, we would be meeting her dietary reference intake for protein on this keto diet at 1,500 calories. And then with carbohydrates, it's typically quite low. So 10%, in this case, 38 grams, which is, almost 100 grams under the dietary reference intake for Amanda. So nutritional ketosis, lots of people get a little concerned about, when they hear keto or ketosis because they confuse it with ketoacidosis. It is quite different. The brain is fueled by metabolic byproducts of ketosis rather than glucose. So the 130 grams of carbs is largely based on supplying adequate glucose energy to the brain. But in ketosis, the brain can run on ketones. So particularly beta hydroxybutyrate and acetoacetate has become the fuel in lieu of glucose for the brain. So most keto plans limit total carbs to 20 to 50 grams per day. It does shift metabolism from glucose to ketones. It was originally used, interestingly enough, to treat neurological disorders, often seizure disorders. And foods that would be included in this plan would be things like fatty fish, eggs, meats, high-fat dairy products, nuts, seeds, olives, avocado. Low-carb veggies are permitted, starchy veggies are not, herbs and spices, and limited use of berries. So there's really very little fruit incorporated into a keto diet, but berries in particular are low carbohydrates, so maybe included in small amounts. Caution here is to not go too high with the protein because protein can be converted through gluconeogenesis to supply glucose to the body, and so thereby disrupting the keto process, the keto metabolic shift. Low carb is also one that people will come in and inquire about and be interested in pursuing. So in this case, our fats are not as high within our percentage as they are on keto. So typically a low carb might have a distribution more like 30% fat, about 40% protein, and under 30% carbohydrate. There's no agreed upon definition of low carb. Commonly a range of around about 26%, or as I say, under 30% is used in calculations. So if we were applying this to Amanda at a 1500 calorie diet, she would be getting about 98 grams of carbohydrate a day, so under the 100 gram threshold, about 150 grams of protein, much higher than the keto, about 100 grams higher, and only about 57 grams of fat. And so low carb, again, no clear definition. Protein is often the thing that is swapped for carbohydrate as opposed to adding significant fat. And we do know that there's significant preservation of lean body mass on low carb by comparison to some of the keto plans over longer periods of time. So what we would be eating on this plan: meat, poultry, fish, seafood, eggs, high protein dairy like Greek yogurts and Icelandic yogurts, high protein vegetarian foods like legumes, more like tofu and tempeh. Legumes are a little high in carbohydrate for some of the low carb approaches. Nuts, seeds, and non-starchy vegetables. Fruit, starchy vegetables, and whole grains would be used in very moderate amounts. And a third highlight would be more of the plant-based approach. Plant-based approaches tend to be our higher in carbohydrates, more than 50% carb, and so are more along the lines of the dietary reference intakes. They do tend to have moderate proteins and again, kind of a moderate fat range. So for Amanda, if again applying the 1500 calories in a plant-based approach, she would be targeting more like over 200 grams of quality carbohydrates here. There's a difference. Proteins at about 56 and fat at about 50 grams. So again, we're looking at foods to eat here. This is a diet primarily based on plant foods, fruits, vegetables, starchy vegetables, whole grains. The legumes, beans, peas, lentils are much more prominent here. It's much more rich in some of the non-dairy milks, plant-based condiments, certainly lots of herbs and spices. You'll notice in the pictures that I've been showing a lot of whole foods, a lot of minimally processed foods. And that's important. And it become particularly evident through a study, again, with Kevin Hall, who is one of the gentlemen behind the Body Weight Planner, that compared ultra-processed diets versus unprocessed diets and their impact on weight and ingestive behavior. These images I'm showing here are matched, they're meals that are matched for their caloric, macronutrient, and fiber value. So if they were to be put into, a food journal analyzer like MyFitnessPal, numerically they'd look the same, but they're very different when you look at them. Here we have some highly processed ingredients, the hot dogs, the chips, the juice, the sugar sweetened yogurt. Here we have very unprocessed. And ultra processed foods are typically high in sugar, sodium, and fat and provide little nutritional value. And whereas look at the volume difference when we're looking at this unprocessed. What they found in this study, so it was a controlled feeding study of sorts where people did have ad libitum access to food of these two diet types, was that when ultra processed meals were presented, people tended to eat more like 3,000 calories over time versus 2,500 calories on the unprocessed diet. So a difference in the range of not quite 500 calories between the two, because they could go back for more. And what happened to weight change, this was a 2-week study, so a short intervention, was pretty significant. So a change from baseline of almost a kilo when eating the ultra processed diet versus a decline of almost the same amount on the unprocessed diet. So promoting unprocessed foods and quality within whatever macro approach you're taking is really key. In Canada, we have something called the Canadian Community Health Survey. Our most recent data was released based on 2015 information. We eat a lot of ultra processed foods. And so it's important to be moving Canadians towards unprocessed or minimally processed foods and less processed culinary ingredients. With whatever our energy prescription is, whatever our macronutrient prescription is, moving to unprocessed foods is key. And so we use the plate method as a way of teaching people a practical approach to planning their meals. It emphasizes cooking from home, using unprocessed, minimally processed foods and culinary ingredients, and focuses on lower energy density and portion control. And this really aligns well with the meal pattern-based approaches that are also recommended in the medical nutrition therapy chapter. There are quite a few of them, and it would be a whole other presentation to dive into each. But I would say that the key ones that have been shown to have beneficial outcomes, they all have some key outcomes, and that's why they were included in the medical nutrition therapy chapter, would definitely be the Mediterranean. So there's some great background around the Mediterranean diet approach on oldways.org, which is in part backed by Harvard School of Public Health in not just promoting the health impacts of these traditional diets, but also preserving the cultural significance of these traditional diets. So Mediterranean, a strong emphasis on unprocessed foods, with the base of the eating centered around grains, fruits, vegetables, plant-based foods. Protein coming from fish and seafood plays a predominant role over meat, poultry, and dairy, and use of sweets very rarely. The portfolio diet is also highlighted in the medical nutrition therapy chapter. This was developed by Dr. David Jenkins and his team out of Toronto, and really focused on some of the cardiovascular benefits of including functional foods in the diet. So nuts, plant protein, viscous or sticky fibers, and plant sterols. And low glycemic index really looks at the carbohydrate quality. So even if you're swinging the carbs lower, you really want to be helping your patients to understand the quality of carbohydrates. And low glycemic index has been shown to be of real benefit in this. Comes out of as well sort of the diabetes world of helping people to understand not just the quantity but quality of their carbohydrates. So it doesn't perfectly align, but generally speaking, the less processed the carbohydrates are, the more high fiber they are, the lower their glycemic index. So green means go, yellow is use in moderation, and red is limit the use. Meal replacements are also spoken of in the medical nutrition therapy guidelines. Meal replacements increase the accuracy of caloric reduction, they improve portion control, they provide good nutrition with calorie reduction, they provide a structured meal pattern and prevent meal skipping in many people. They're useful for people with very busy schedules, traveling and eating out and such. And they can be a tool for weight maintenance in association of healthy diet and exercise. They provide stimulus narrowing, far fewer choices to have to be made in the run of the day. There's a wide variety of formats for your meal replacements, but typically they do not exceed 300 calories per portion. They might be in bar or shake. They usually have less than 30% of their calories from fat. They generally provide 15 grams of protein or more per serving, and they have usually less than 7 to 10 grams of sugar per serving. And they relate to our plate concept in that they provide vitamins and minerals, volume in the shake versions from water. They're rich in protein. They do provide some carbohydrate for energy, some fiber, and some healthy fats. There are variable protocols. Some use a partial meal replacement, so 1 or 2 shakes a day partnered with food. More intensive versions might start out with a full meal replacement and transition to partial. Fasting approaches. So the timing of meals can be augmented with clients as well. So there are variable options here, extended fasts followed by feast periods. So it might be a day of fasting where you consume less than 25% of your caloric needs, followed by unrestricted days. That's an example of sort of the 5-2 alternate day fasting. Or there might be more of a time restricted feeding where we're looking at hours, 8 hours of eating versus 16 hours of not eating versus days. And there have been studies to show that perhaps early time restricted feeding, taking your calories in between the hours of 7 a.m. and 3 p.m. may sync up better with our circadian rhythms and have cardiometabolic benefits that are independent of weight loss. Finally, or nearing finally, dietary fiber is mentioned in the medical nutrition therapy guidelines. The dietary reference intakes for fiber are roughly 25 grams a day for women who are under 50 and 21 grams a day for women who are over 50. Thinking of Amanda, she falls into this 25 grams per day category. The benefits are decreased incidence of diabetes, coronary artery disease, cerebral vascular disease, and many forms of cancer, notably colorectal cancer. But dietary fiber may help to keep staying full. But I think more and more, we're beginning to learn that dietary fibers benefit for our health, and particularly when it comes to weight, might be its interaction with our microbiome. And what we are understanding about this sort of additional organ inside of our digestive tract is that diversity is really key. And what helps to keep up the diversity of our microbiome is feeding it well, sort of the concept of like growing this garden inside of us. And what helps the microbes to grow and diversify are indigestible food components, fibers in large part. So when we talk about prebiotics, many of these are indigestible plant-based components, or what we classically think of as fibers, not exclusively, but in large part. And then definitely our probiotics, so putting into the system active living cells coming from things like fermented foods, for example. When it comes to understanding this as it relates to weight, it's still a very young science, but we're starting to see things like particular groups of bacteria and organisms that might be more associated with weight gain when we're seeing these dominate in the colon, whereas there are other groups that when they dominate, they tend to be associated with either weight loss or leanness. And macronutrients, again, so here in Canada, we've talked about the macros. The micronutrients are all our vitamins and minerals that come from our foods. Common deficiencies in Canada include vitamin D, vitamin B12, and iron in individuals living with obesity. The prevalence of vitamin D deficiency has been reported to be as high as 90%, and it's theorized through decreased bioavailability of vitamin D as it's sequestered in adipose tissues, or potentially due to a volumetric dilution in individuals living with obesity. Systematic reviews and meta-analyses of randomized controlled trials indicate that higher adiposity is associated with lower serum vitamin D, suggesting the need for clinicians to monitor vitamin D status as part of routine assessment for obesity. And vitamin D supplementation has not been effective in treating obesity or specifically for improving cardiometabolic outcomes. Restrictive eating patterns and obesity treatments such as medications and bariatric surgeries and drug nutrient interactions that can occur through medications taken for comorbid conditions can lead to micronutrient deficiencies, and specifically B12 and iron deficiencies seem to be most prevalent. So monitoring for those is important, and repletion either through focusing on foods that are rich in those nutrients or adding supplementation is key. And in Canada, at least, there's growing evidence for thiamine insufficiency, if not deficiency, as well as magnesium. Poor iron status has also been associated with those living with obesity. And there has been about a 1.3-fold increased risk for deficiency in people living with obesity. And so definitely keeping your eye on assessments of biochemical values can help to inform the recommendations for food intake, vitamin and mineral supplementation, and also watching out for the drug nutrient interactions. So in summary, medical nutrition interventions should focus on achieving health outcomes, not just weight changes. They should focus on individual eating patterns, food quality, and a healthy relationship with food that's rooted in mindfulness-based eating practices. Medical nutrition therapy demonstrates benefits with cardiometabolic outcomes, and when coordinated care with a dietitian, it helps to improve health, not just weight, and quality of life. And the focus of all nutrition interventions should be an approach that fits the client's life, is culturally acceptable, is affordable, enjoyable, and is effective for long-term health improvements. So with that, I thank you for your attention, and I haven't been able to pay attention to the Q&A as I go. So if there's, I'll stop my screen share there, and I'd be happy to take questions if there are any.
Thank you, Danielle. That was excellent. You covered everything on dietary intervention and obesity management. That was really good. I actually have a lot of questions, but I will limit a few. So question number one, there is someone is asking whether is it safe to combine low-calorie diet less than 1,000 with an hour of moderate physical activity in a patient with no comorbidities?
It's a great question. I think we would probably want to do an assessment of their physical capacity and just be conscientious about, you know, I'm assuming this is a patient maybe without diabetes, for example. We would be encouraging them to start where they are and increasing their activity slowly. A low moderate intensity activity like walking might be totally doable and acceptable, especially if they have been somebody who's been walking. So if their level of fitness is already pretty decent. If it's somebody on hypoglycemic agents, anti-diabetes agents that put them at risk for a low, I would just be careful to educate them about signs and symptoms of lows and appropriately treating those. But in our clinic, we do have individuals who follow a 900 calorie pattern and do incorporate routine exercise. Some of them find that, you know, during that intense restriction, they have to just dial back on the intensity or frequency of their activity. So I think it can be done. It needs to be monitored, and the pros and cons or the safety elements need to be educated on.
Very good. So my question is, for patients who have a pre-existing condition, would you recommend one diet rather than the other based on their medical conditions? For example, if they have diabetes, would you recommend a low carb diet versus a nutritional ketosis, especially now that it's actually coming into some of the guidelines like ADA, and most recently like the Canadian Diabetes Association made a statement on a nutritional ketosis. So based on that, would you recommend it to patients to give it a try and or?
Yeah, so I think this is again where you're assessing the patient, what's doable for them and what might fit their needs. And I think about the Diet Fits study that kind of looked at that quality low carb versus quality low fat approach, and we did see that you know, there wasn't a whole lot of difference from a blood sugar perspective in terms of the management there, that people did well on both, But something like triglycerides was much more improved on the low carb approach than it was on the low fat approach. So I think there is some evidence to say that you might lean one way or the other based on what the person is presenting with. And I do think that when it comes to diabetes management, you are looking to educate your client on carbohydrate quantity and quality, and probably working to go a little bit more moderate, if not low carb.
Very good. In patients with PCOS, I was asked actually this question in another conference. In patients with the polycystic ovarian syndrome, would you think there is one diet that's better than the other? Or what do you think about the evidence in like polycystic ovarian syndrome?
I think polycystic ovarian syndrome and our classic approaches to diet with other insulin resistant conditions like diabetes and weight overlap quite a lot. And so again, I think this is a category where we're looking to moderate our carbohydrate intake, if not low carbohydrate intake. But fiber is really important in this group too. And so when you go lower carb, you sometimes sacrifice fiber intake. And so there's where I'm trying to sort of look at the client and figure out what's that right level. Because if we can preserve a certain percentage of carbohydrate and really emphasize quality carbs within that, we also get the benefit of having that dietary fiber, those prebiotics, then that can be helping us to fuel that microbiome and having its benefits within the disease management process too.
Very good. I have a question here. How to answer patient who is on keto diet and found sudden increase in his LDL level?
So yeah, it's interesting, right? Because keto, so quality matters here too, right? We've been talking quality of carbohydrate, but we really do also want to think about the quality of the fat. So traditionally, keto has emphasized a lot of saturated fat. And so I think we need to kind of dig into the shifting a little bit more of that saturated fat towards unsaturated fat sources. So, rather than the high fat meats, maybe we're looking more towards the oils, the avocados, the olives, the things that are going to give us a little bit more of that unsaturated fat component within that higher fat approach.
Very good. Another question, I think we already answered this question, which is a case of hypertension, obesity class 3, prediabetes, and adult polycystic kidney disease. Which diet is good for her? I think I will just change the question a bit on the prediabetes, kidney disease, liver disease, like the protein intake. Specifically, maybe would you limit the protein intake, or like doing a low carb diet which has a higher protein intake compared to other types of diet?
So sorry, you were cutting out just a little bit there. So we're thinking moderate protein because we had some kidney concerns with this patient. Yeah. So I think when we're assessing protein needs from a kidney perspective, classically, and I may have missed the kidney stage, and I have to admit I'm not a kidney specialist or nephrology specialist dietitian, but sort of 60 to 80 grams of protein per day if they have reasonably preserved kidney function is fine. And so if we were looking at keeping their protein intake in that zone, so when we were doing the breakdowns there, that sort of moderate to lower carbohydrate approach, we can be keeping kind of like at 1,500 calories, sort of a 40% carb, 30% protein, 30% fat, or even a 30 carb, 40% protein and 30% fat will kind of keep you under that 80 gram of protein per day zone. So it's kind of both looking at it from a percentage, but an absolute gram perspective. And typically 80 grams of protein or less is typically used when we're talking about kidney management.
Very good. I think I'll take this as a last question. Regarding pregnancy with obesity, can we apply a specific diet?
So I think from my perspective, Canada's healthy eating guidelines, Canada's Food Guide to Healthy Eating, is what we would typically apply to pregnancy. and obesity management. And our focus shifts from weight loss to appropriate gains in pregnancy. And so we know that typically women who are entering pregnancy at a higher body weight, we have actually a tool on Health Canada's website that helps us to understand that the weight gain is probably not the full 25 pounds that we typically look at for the structures that support the pregnancy. So blood volume increase, the baby's weight, the placental weight, breast tissue increase, all of that. But that we are sort of scaling that back a little bit, knowing that all of that is still going on, but we are going to sort of tap into the mom's reserves a little bit to help build those structures. So the focus really shifts from weight loss to an appropriate weight gain and fueling mom and baby effectively. And quality is really key there too. So making sure the diet is nutrient dense. So you're eating twice as well, not twice as much.
Very good. Just one more question just came because it's around the same topic. For patients with gestational diabetes, can you reduce carbs less than 130 grams per day? We rarely see that with pregnancy in obesity clinic.
Yeah, and because maybe, I'll say maybe. And I think I'd have to dig a little bit more into sort of like the fetal glucose metabolism there, just to be sure that we aren't pushing the limits too much. It's a great question though. It's a really good question. I don't have the answer to it off the top of my head.
Very good. Excellent. Thank you so much, Danielle. That was an excellent talk, and we are really happy to have you with us. And hopefully in the future, maybe on site in Oman, you will invite you to come over. And that was an excellent talk. And thank you also, Dr. Shao, again. And I think we will say goodbye until tomorrow. So tomorrow we have 2 other sessions. The one start at 5 p.m. The first one will be on psychotherapy and in weight management. The second presentation will be around pharmacotherapy and weight management as well. So we'll see you tomorrow, everyone. And thank you, Danielle. Have a great Sunday, both of you. Dr. Shao.
Thank you so much.